Yeah, okay.
Keep it on mute, please. Otherwise, there'll be an echo.
Right, go.
Is somebody
And you need to answer to all the delegates' questions on that chat.
So is somebody assigned that to take a question and answers and convey it to you?
No,
all
so
faculty would go. Yeah.
All the faculty are on the YouTube, and the pertinent questions they would be answering to the delegates there and there on the YouTube chat, pertaining to their topic. And of course, others are welcome to answer as well.
Probably if the two devices are open at a time, there will be echoing.
Yes, so we need to put them on mute. Just put the volume to 0.
Yeah.
Good morning. We are live.
Yeah.
Okay, ma'am.
Morning.
Ma'am, you're muted. Rujita, ma'am.
A very good morning to everybody. On behalf of the Bombay Orthopedic Society, I welcome all of you to the second master series, which is focused on arthroscopy and sports medicine. The theme for this year has been practice-changing ideas in every field. And who better than the stellar starcast today, which has been chosen for delivering the concepts. What we see over the years is that Scopy itself changed the face of orthopedics by being a very niche super specialty. And then the entire cosmos within Scopy changed in terms of the approach to some of the problems. So our brilliant conveners have chosen very, very selected topics where really there is a lot of looking back and looking forward, which will happen today. And without much ado, I will now move on to the main housekeeping announcements and then ask Dr. Pranjal Kurkani, our convener, and Shreyas Gajjar, our co-convener, to take over for the day. I will request all the faculty to keep their audios and videos on mute when one of the talks is running. All the faculty will be available live, although these are pre-recorded talks, to answer the questions on the YouTube link. So I request to the audience to send in their questions and address it to a specific faculty. And both the moderators will also be on standby for the same. So without much ado, I hand over the proceedings to Dr. Pranjal, and Dr. Sangeet and Swapnil can welcome the audience as well.
Dr. Swapnil, would you like to get?
Yeah, so on behalf of the Bombay Orthopedic Society, I welcome all of you all to this second wonderful Master Series webinar, which is online this year. And may I request now the President, Dr. Sangeet Gawale, to kindly deliver the welcome address.
Greetings and welcome to all the members of Bombay Orthopedic Society. As said, this is a second master class and we have chosen specific topic and specialities. So we have a good 4-hour session from the eminent faculties on Scopy reconstruction and on shoulder and knee. So don't go anywhere, stay for these 4 hours. It will be a great learning experience. And so next clinical meeting, it will be on Cyan and hope to see you face to face partially. I hand over to Pranjal to start the proceedings for the today's webinar.
Thank you very much. Firstly, let me thank the Bombay Orthopedic Society and Dr. Rujita Mehta for giving myself and Shreyas this opportunity to convene this master series. I welcome all the faculty members and thanks for your wholehearted support in recording your talks and giving them on time and making this a smooth affair. What we've included in this master series today is some common pathologies that we come across in our day-to-day practice in shoulder and knee arthroscopy. However, there has been a sea change in the way to their management and their approach to management. And therefore, there has been a practice change in the way we handle these pathologies. So to start off with, we have the first talk by Dr. Anand Joshi, who's going to speak to us on meniscus tears, advances in current understanding and management. So I'll be putting on the videos that have been pre-recorded. But all the faculty are live over here with us, and they will be ready to answer all your queries on the YouTube that you are on now. So, and you will be getting replies from all our faculties.
Over the past decade, the meniscus, a key player of the knee, has suddenly come into the limelight. And I can think of a number of reasons for this. We have the powerful Save the Meniscus lobby, the Joint Preservation Brigade. We have immense peer pressure. You sound almost like a criminal if you even utter the word meniscus, and possibly because of better understanding of the problem. Suddenly, from being a proverbial sacrificial lamb, the meniscus today is a hollowed component of the joint. The surgical strikes against this meniscus seems to have originated in Scotland. Thomas Annandale, repairs and resection of the meniscus. The Brits had to oppose the Scots, and sure enough, Bland Sutton, a British surgeon, then labeled the meniscus as a functionless remnant of leg meniscectomy. Ian Smiley, an eminent knee surgeon, seemed to have got it all right, but only backwards. He felt that a torn meniscus results in an ACL tear and chondral wear. And therefore, his message was that if a meniscus is torn, sooner a meniscectomy is performed, the quicker the recovery and better the long-term result. I vividly recall Dr. Dholakia telling me that during those days, our own footballers in Calcutta were often subjected to meniscal removal to prolong their playing careers. This example is a classic one of philosophies of one age seem like absurdities of the next. The era of arthroscopy was, in a sense, a meniscus savior. It helped us in precise diagnosis, and the meniscus was no longer the scapegoat of the knee. We progressed from total to partial meniscectomy and even repairs. But before I go to saving the meniscus, a bit about shaving the meniscus. In few cases, the meniscus cannot be salvaged, and some of the simplified indications for meniscectomy are the meniscus which is developmentally defective, like a discoid meniscus, or one that is chronically torn or deformed, like a flap tear or a ruptured bucket handle tear of the meniscus, and in very few and rare cases, a degenerated meniscal flap which causes mechanical internal derailment. Besides these indications of the state of the meniscus, it is also the patient's demands that often dictate or need a meniscectomy. For example, elite athletes in a season who have a meniscus tear often prefer a meniscectomy over the uncertainties of a repair. But before you reset, I think the decision making has to depend on patient symptoms, a proper detailed clinical examination including the gait of the patient, weight-bearing x-rays, and of course MRIs to show you any associated injuries and chondral damage. Meniscectomy is a skillful operation, and I have seen surgeons who have even authored books messing up the knee or abandoning a meniscectomy. The approach to the meniscus through the correct portal, defining the tear by proper probing, planning the resection, and choice of the right instrument are all things that matter during a meniscectomy. In this case, I have opted for a small joint upbiter to incise the posterior horn of the medial meniscus in the tight knee. When it comes to the shaver, we have used non-aggressive shaver blades which have lesser chance of injury to the articular cartilage. Any overhang of the meniscus needs to be trimmed, and balancing of the meniscus needs to be carried out to prevent any secondary changes. So a well-done meniscectomy can often give you long-lasting results, and in our practice, we have patients who have been satisfied for almost 20 years after a perfectly done meniscectomy. When you have a meniscus tear associated with the cyst, excising the tear alone is not enough. One has to decompress the cyst both from within and from without. In this video, you can see the gelatinous material coming out of the torn area. A spinal needle is then introduced from outside in, and then this is followed by a small joint shaver, which then helps you to excise the wall of the cyst, and this prevents recurrence of the cyst and gives symptomatic relief. Poor and sometimes poor execution of the meniscectomy itself. A wrong portal, large diameter and aggressive instruments all spell doom for the knee, as can be seen in this case. The surge in meniscal repairs seem to be due to earlier diagnosis and patients seeking treatment early. In the past, patients often came to us very late when the meniscus was already irreparable. The ideal tear for repair is, of course, a longitudinal tear in the vascular zone without any secondary tears. The ease of reducibility matters, especially in a bucket handle tear, which is long. And when repairs are carried out with ligamentous reconstructions, the outcomes are even better. Meniscal repair techniques are selected according to the area of the tear. The outside in is for the anterior horn tears, the inside out for the mid segment, and the all inside is reserved for the posterior horn area, where you are dangerously close to the neurovascular structures. Inside out technique in our hands is the gold standard for majority of our meniscus repairs, and here is an example of a bucket handle tear in the red zone. The bucket is reduced. Rasping and synovial abrasion are done to enhance the healing potential and freshening the edges of for adequate repair. The single lumen cannula is then passed, and double arm needles then introduced, both on the superior as well as the inferior surface of the meniscus. We space the sutures on both the superior and inferior surfaces for better coaptation of the tear. For the posterior third, especially on the lateral side, we opt for all inside fixators. And with the newer malleable devices, one can place these implants in the tight spaces like the inferior surface of the lateral meniscus, as is well shown in this video. When repairing isolated meniscus tears, we augment the repair using a fiber clot to enhance the repair potential. 20 to 40 cc's of the patient's blood is taken and prepared in a glass crucible, and the fibrin clot introduced before the sutures are finally snugly tied. In some cases, like in a discoid meniscus, one may have to combine dissection with repair. In this discoid meniscus, the inner deformed portion of the meniscus is excised, and in the periphery, the tear is repaired so that the rim can be preserved and normal meniscal function can be restored even in a discoid meniscus. Although meniscal repairs seem to be very attractive, we all know that there are significant percentage of meniscus repairs which years, and in our experience, this can happen even in the ideally selected cases. And we feel that the failure of meniscal repair failures fall almost in the 50% category. Are we pushing the repair envelope? We have seen surgeons repairing and leaving behind misshaped and deformed menisci, fixing a radial tear through 2 tunnels, and immobilizing a meniscus which normally should be mobile. As can be seen, the meniscus is attached only at the roots, and the mid portion of the meniscus is supposedly mobile. But when you drill transtibial tunnels and fix this menisci, it is really a logic-defying repair. Coming to hidden lesions of the knee and 2 main meniscal lesions which are found in the posterior third of the knee, and a site which is frequently overlooked by arthroscopy is the meniscus root, which has been touted as a silent epidemic of the knee. It has caught the fancy of the surgeons because shown that meniscus extrusion, increase in peak contact pressures, accelerated contral wear is almost equal to a total meniscectomy. The lateral meniscus root is commonly on the medial side is seen in the relatively atraumatic in the degenerative. The classic present 5 to 55 years of age. There's an episode of painful pop or click in the knee with sudden immobility. The lotus position, which was previously believed to be a cause of root tears, is not so. This happens with relatively atraumatic episode. The complaints are extremely vague with feeling of something not right inside the knee, and the pain may be felt at the back of the knee, or there could be radiation to the calf. There are no real clinical signs to diagnose root tear, and in our experience, it is a typical MRI finding which helps us in diagnosing a root, like a transected root, early extrusion, the ghost sign, and the typical edema which is seen in the posterior aspect of the tibia. During MRI evaluation, one must evaluate the degree of extrusion and the extent of chondral wear. Because if the degree of extrusion is significant, your sutures are not competent. Various root repair techniques have been described: the transtibial, the all-inside fixator, and the suture anchors. The transtibial technique is one which is popularly used in majority of practices. A suture passer is introduced to pass sutures about 1 centimeter away from the edge of the tear. Sutures are retrieved and the sutures are tied over the tibial aperture over a button. This is an example of a lateral meniscus root tear which was associated with an ACL rupture. Has been used upside down to retrieve the suture. The suture is then replaced by a fiber tape so that a broader surface area is available for repairing of the root. The ACL jig is placed at the appropriate and a 4.5 mm tunnel drill with a cannulated drill. A shuttle relay is passed and the the fiber tape retrieved through with the help of the shuttle relay and then tied over a button on the tibial side. And this is the final appearance of a repaired lateral meniscus root. Are we going overboard with our roots, and are we selecting our root cases prudently? Here is a case of a 62-year-old female. An MRI showed that she had a transected root, no relief from her symptoms. And when she came to us and when we had her weight-bearing X-rays, we realized that she had a complete collapse on the medial compartment. So during a case for root repair selection, I think watching the gait of the patient, a red flag is when the patients have a significant varus thrust or their scanograms reveal that there is a more than 5-degree varus deformity. We next come to another hidden lesion of the knee, the so-called ramp lesion.
which is a meniscotibial capsular separation, which happens in almost 18 to 20% of the ACL deficiencies. Neglect of these can lead to persistent or subtle instability and early ACL graft failure. To identify these, one needs to approach the ramp area, which is the area, the scope is gently introduced between the medial femoral condyle and the PCL. Joint distension should be adequate, and a small diameter arthroscope helps you assessing this area easily. There are various ways by which a ramp, once identified, can be repaired. Our choice is, of course, the inside-out method of fixation, but you can also do it with a fast fix or an all-inside fixator. Here is an example of an all-inside fixator repairing the ramp. This is an article which we published in the Arthroscopy Techniques, where we have demonstrated a satisfactory outcome following a ramp repair using inside-out technique. And this is a technique which we commonly use in our practice because it gives you the flexibility of passing sutures both on the superior as well as the inferior surfaces. We now finally come to the salvage procedures in a meniscus deficient knee. And we have two such procedures. One is for a partial replacement with a scaffold, and the second is a meniscal allograft transplantation. Meniscus scaffolds are of two types, the collagen-based and the polyurethane-based. I have no experience, but my partner Bhushan Sabnis has experience with these. And here is a video from his work. The medial side degenerated meniscus is repaired. The posterior and anterior horn need to be intact when you are doing collagen replacement. The ruler is used to measure the exact size of the scaffold. Oversizing is always recommended because there is a possibility of shrinkage of the collagen material. Once the scaffold is introduced inside the joint, various suture techniques can be used to fix it. And the results of these have failure rates of almost 31.8%. And the matter of concern in these is very often reduced volume with time, or even complete absorption of the implant and exclusion of the scaffold. And hence, these scaffolds are, the use has not really become very popular. We finally come to a salvage situation in a young individual who has what is known as a compartment at risk syndrome following a medial or a lateral meniscus meniscectomy. And in these patients, in order to provide the function of a meniscus transplants using allografts is done. The meniscal allograft transplant can be used either with transosseous sutures, which is commonly on the medial side, or with bone plugs. But on the lateral side, the bone bridge technique is what is preferred because it gives you a better hold, and both the anterior and posterior horns distance can be well maintained by technique. This is from my friend Professor Kim in Korea, and he does about 100 of such transplants every year. The drawback in this is, of course, the cost of the implant, which is exorbitantly high in our scenario, and also the easy or the non-availability of these implants in our country. So finally, to summarize, I think we have come a long way in meniscus tear management, from total to partial, to repairing vascular to avascular zone, restoration, even meniscal implants are being introduced gradually, and these are things in the future. So I think today we have three basic options when we talk about meniscal lesions: save the repairable meniscus, shave the irreparable one,
and salvage the meniscus deficient. Thank you very much.
So thank you very much for that excellent talk. Dr. Joshi, I'm very sorry. I just noticed on the YouTube that my video was running over there. So I'll just try to rectify that in the next presentation.
Okay.
Let's go on to the next talk. I think, Pranjal, we are clubbing all the talks together and then taking the questions. I can already see a lot of questions for Dr. Anand Joshi. Meanwhile, can you load the next talk, please? Yeah.
Yes. So the next talk is by Dr. Abhay Narvekar on ACL deficiency, much beyond ACL reconstruction. Is my video off? I'm just checking. Is my video off?
No, you will, Dr. Pranjal, you will need to turn off your camera.
Is it off?
Yes, yes.
Okay.
Good morning, everybody. At the outset, let me thank Dr. Shreyash Kajjar and the Bombay Orthopedic Society team for inviting me for this session of Master Cares and Master Shares. My topic for today is ACL deficiency, much beyond reconstruction. It's a long topic, so without further ado, at least one thing is very clear, that ACL is the primary ligament of the knee. And the adage that an ACL tear is the beginning of the end of the knee is very well understood by everybody. But today we are not talking about ACL reconstruction per se, but we are talking
Dr.
about
Pranjal, your video is not running.
beyond ACL reconstruction in order to provide adequate results. Now, if you have seen through the evolution of ACL surgery, we all started off doing ACL surgery.
Pranjal, I think we need to stop and start all over again with this one. Audience, please bear with us.
Okay. The video is not seen, is it?
Nothing is seen.
Good morning, everybody.
Nothing is seen.
At the outset,
Nothing is seen. We just see some. Pranjal, do you want me to do it?
If you have the talk, yes. If you can take over.
Can you please unshare, please?
Dr. Shreyas, we can't hear the sound. If you are wearing earphones, please remove them. No, kindly unshare the screen. Let me see if I can run it from my end.
Good morning, everybody. At the outset, let me thank Dr. Shreyash Gajjar and the Bombay Orthopedic Society team for inviting me for this session of Master Cares and Master Shares. My topic for today is ACL deficiency, much beyond reconstruction. It's a long topic, so without further ado, at least one thing is very clear, that ACL is the primary ligament of the knee. And the adage that an ACL tear is the beginning of the end of the knee is very well understood by everybody. But today we are not talking about ACL reconstruction per se, but we are talking about things that one needs to do beyond ACL reconstruction in order to provide adequate results. Now, if you have seen through the evolution of ACL surgery, we all started off doing ACL surgeries probably in 1900s with the first thing that was ACL repair. And then people started doing extra-articular reconstructions. We then went on to the transtibial ACL, a single bundle, a double bundle, then remnant preserving, anatomic ACL reconstructions, back to repair, etc. And the whole idea was basically to try and replicate the structure and function of the ACL. But if you look at the structure of the ACL, you'd realize that besides extensive amount of water, what it also contains is type 1 collagen, some amount of other types of collagen, elastin. So it's a combination of a lot of
Has the audio just gone off?
Audio is gone again.
Even
Dr.
today,
Dawale?
there is a 25% failure rate in young and active athletes. If you talk about osteoarthrosis, I don't think ACL really prevents osteoarthrosis. As a matter of fact, there are papers which say that it actually enhances osteoarthrosis in people. If you look at the athletes, only 65% can get back to their pre-injury level. So we are far from being perfect or far from being reasonable in doing ACL reconstructions with the aim of getting people back to their original level of activity. And therefore, we started looking around in order to find out how we could improve the results, not just trying to reconstruct that ACL, but looking at other things that would help to improve our results. And for that, I think you need to assess a person with an ACL injury in various ways. The first thing is, what is the type of injury? Is it a low velocity, contact injury, non-contact injury? The sex, it plays a very important role because females have a very different way of responding to the ACL injury as compared to males. Age, all of us know that different age groups would have different types by which their demands would be different, and therefore their response to ACL reconstructions would be different. Anticipated level of activity is very important because those with higher level of activities which are anticipated, the chances of failure on a single ACL reconstructions are higher. You got to look at what is there in the opposite limb, whether he has already suffered from an ACL in that opposite limb, because that would put some red flags above. Associated injuries, you've got to assess them, you've got to treat them so that the loads on the ACL do not increase. And finally, whether that person who has come for ACL reconstruction, is it a primary reconstruction or is it a revision reconstruction? So on the other side, we have the option of doing an ACL reconstruction, an option of doing an ACL repair or an augmentation. If there are meniscal tears, then we need to look at the menisci and repair them, do the ramp lesions, look at repairing the root tears. We've also got to decide the grafts that are to be used, how to manage the associated injuries, whether one needs to add a little more stability to the ACL reconstruction that we plan to do by an anterolateral ligament reconstruction or a lateral extra-articular tenodesis. Got to also see where one can do probably a high tibial osteotomy and maybe what would be the role of changing the tibial slope. So it is a sort of mixing and matching different types of injuries, sex, etc., with the type of structures which are affected and try and see to it that we are able to get all this together so that we eventually provide a very good result. Now, I would go one by one with each one of them, and probably the most important and the one which has been neglected all these years has been the ramp tear. Now, ramp tear is something which is new. It has been described by Gilchrist way back in 1983, and he described it as a peripheral capsular injury on the posterior aspect of the knee. And if you look at the biomechanics, you'd realize that when there is an anterior tibial translation, the semimembranosus, which is attached directly onto the posterior capsule and to the meniscus, obviously contracts in order to prevent that anterior translation, giving rise to this particular tear peripherally. And once you have this tear of the capsule posteriorly, it would obviously increase the anteromedial rotatory instability. And therefore, we know that if the anteromedial rotatory instability were to increase, the load on the graft is bound to increase. So if you look, this is how the MRI picture of the ramp tear would look like. If you were to do an arthroscopy, this is how the posterior capsule, the femoral condyle, the periphery of the meniscus, and this is exactly where one tends to get the peripheral capsular injury. Basically, the treatment can be done either by repairing it from outside, or it can be repaired well from inside. You can use this various types of now available devices in order to do a quick repair of the posterior medial capsule and the posterior portion of that meniscus. Now, way back in 2011 and repeatedly by Robert Arciero and Di Filippino, what we realized is that what they did was that they gave 150 newtons of force, of an anterior translatory force on the tibia at 30 degrees of flexion. And what we realized is that if a person has got a ramp tear, then the amount of translation is significant. If there is no ramp tear, then you realize that the translation is almost half. And if you were to repair that ramp, this is somewhere in between, but closer to what would happen in an intact meniscus. And therefore, it obviously proves that a ramp repair decreases the translation, improves the anteromedial rotatory instability. It is more common in revision ACLs. You got to repair it because if healing occurs, then you would increase the stability of the knee. And we know that spontaneous healing is improbable. And that is why very often in revision ACLs, when one goes to see, you still find those unhealed ramp tears. The next thing that we look at as far as the meniscus is concerned is the root lesions. Now we have both medial as well as lateral root lesions. It depends upon the slope. If the medial slope is more, one tends to have more of medial root tears. If the lateral slope, which is obviously more generally than the medial slope, you would have a lateral root tear. Now, generally these tears can be repaired fairly easily. You can have this type of a quick sutures that can be put through the posteromedial aspect of the remnant of the meniscus, make a tunnel and pull out those stitches onto the anteromedial aspect of the tibia. Similarly, one can do that on the lateral side. Lateral is much easier than the medial because the lateral root is more anterior than the medial root. We know that once we repair the lateral root, the pivot shift very often is seen to decrease. The next thing we were talking about is the ACL repairs. Now, ACL repairs were first performed probably 120 years ago. They were popularized by Palmer. It was one of the common procedures that were done very early in the 70s. However, there was one landmark paper by Fagan where he showed a very high percentage of failures following ACL repairs, which led to its abandonment, and then ACL reconstruction became the gold standard. And ever since, people have been doing ACL reconstructions. However, there has again been a little bit more interest in the ACL. The reason being two ways. One thing is that histologically, one has found that there is a significant reticular leash of vessels at the proximal and at the distal portion of the ACLs. That means the proximal and distal portions of the ACL, if they are injured, are capable of healing by virtue of the vascularity which is there. And once that occurs, these vessels are known to grow into the ligament and align themselves along the ACL. However, the middle portion does not have these vessels, and therefore, if you have tears in the middle portion of the ACL, you would find that these particular tears never heal. And that is the reason why people started doing ACL repairs for proximal avulsions. And there were two very important papers, one in 2015, the other in 2016. And this was primarily by Gregory D. Phyllis. And they've had very encouraging results. And this sort of encouraged us also to start doing ACL repairs. But you need to have a suitable candidate. That means person who has a proximal avulsion. You need to have a suitable tissue in the form of a proper stump. You need to have its integrity to be good so it can take the stitches and the locking mechanism that you are going to use. Now, essentially, it's a very simple procedure. If there is a proximal avulsion such as this, where there is fibrous tissue attached proximally, you need to use these suture passing devices, and you pass them in a bunnel fashion from the proximal, from the distal to the proximal portion of the remnant. And once you have passed these sutures, maybe pass two, for each bundle you pass one, then you can use one of the shoulder devices, increase the biology by putting some multiple holes, and that's how you would get a nice, good, tensed ACL repair, which looks almost like a normal ACL. We've done quite a few of these cases, and I can show you some of the MRI reports. This is an 18-month follow-up. This is the pre-op, that is the post-op. So you have the pre-op, 18 months post-op. You have a nice, good, remodeled sort of ACL. You also have some more. So this is how they look like in the pre-op. This is how they would look post-op. As a matter of fact, we've even taken at 3 months and 6 months. This is how they would look primarily, and this is how the repair looks at the beginning of 3 months. So remodeling occurs beyond that time. So our overall results have been extremely good. We've had a good stability in 93% of cases. Our Lishon scores have been almost 87, which is very comparable. So today, if we were to probably talk about ACL reconstruction, we are also going to basically contribute to what is called as an ACL preservation. Now, when we talk about ACL preservation, we know that we can repair these ACLs if there is a proximal avulsion. And when we talk about proximal avulsion, it means that more than 90% of that ligament is still present. When you have this sort of a situation, and if you have both bundles gone, we have excellent to good results when with or without an internal brace. We'll see what an internal brace is. So if there is more than 90% of the remnant, you do a repair of both bundles. If there is a single bundle more than 90% preservation, then you do an augmentation and repair. And if you have something which is 75 to 90%, then you would not only have to repair both the bundles, but you would have to also augment it with probably a fiber tape or some such device. So this is what you see. This is the avulsion of the ACL. And what we are doing here is, again, what we have shown you just now. We are going to repair that. And after repairing this, we have the fiber tape, which is then passed through. And you have a situation where there is a repair plus the fiber tape. This fiber tape basically acts in order to provide an additional stability during the initial course while the repair is healing. It sort of protects that ACL, which is vulnerable in the first few weeks. There are other methods by which one can also do this. You keep these are called remnant preserving ACL reconstructions, where we take a proper stitch onto the remnant, and then we can pass the ligament, the reconstructed, the hamstring graft through its center, so as to bring about a tension on the remnant. So the remnant is not just fallen down, it sort of is tensed up and is attached along with the reconstructed ACL. So you can do it through it. You can also do it next to the remnant. So this is how you can see there is a remnant there. And what we do is we take a couple of stitches on that remnant, and then we pass the hamstring graft, which is basically going to act here as the posterolateral bundle. The anteromedial bundle, which is intact, is then incorporated so that you have tension on both of them, which is more or less equal. So these are remnant preserving things. The next aspect that we are going to look at is providing rotational stability. The rotational stability that is provided by the ACL Okay, if you were to compare the amount of forces whenever there is a rotational stress on the ACL, you'd realize that it is 6 times the force that is seen on the lateral ligaments or the anterolateral ligaments. And this is the simile, as you can see, that if you were to control the steering, it is better to control the steering from the periphery rather than the center. So if you want to provide a rotational stability, it is necessary to provide some sort of a restraining force on the periphery rather than in the center. And that is exactly what is being done today with what we call as the anterolateral ligament or the lateral extraarticular reconstruction. Now, this is a very simple procedure. It's a lateral incision that is taken, and you take a 10 millimeter strip of the IT band, keep it attached to the Gerdy's tubercle, pass it deep to the fibular collateral ligament, fix it proximal and posterior to the lateral epicondyle in basically 30 to 60 degrees of flexion in neutral rotation. Obviously, you do not want internal rotation because then you are subluxating the tibia. You do not want to keep the limb in external rotation because that would increase the tension too much on the lateral structure. And that is why it should be in neutral position, anywhere between 30 to 60 degrees of flexion. So this is how it would finally look. This is our, this is the LCL, and this is the IT band passed deep to it and then fixed with an interference screw proximal and posterior to the epicondyle. So when do we do this? We do this whenever the person has got a high-grade pivot. So when you're examining, you find that there is what we call as an explosive pivot. It occurs very easily, even without anesthesia. When you are doing ACL reconstructions in young patients who are getting back to pivoting sports. So if the person is going to be some sort of a gymnast who's going to be pivoting a lot, or a basketball player, you would definitely think of providing a rotational stability by basically adding this procedure. Female athletes with recurvatum, because we know that these are likely to rupture their ACLs. In obese people with a BMI of more than 30, and almost always in revision surgeries, because you want to have one surgery and that's it. Now, if you look at basically the results, this is an excellent paper. It's a prospective study of 90 patients on whom an ACL reconstruction was done and on whom an ACL reconstruction with an LET was done. They were followed up for 100 months. And what did we find? That 16% of these had failures when you did only a reconstruction, whereas the failure rate was only 3.5% when an LET was added. Now, if you were to look at results of Andy Williams, and this is something that he has reported of 457 elite athletes, and he reported on his re-rupture rates. And what did he find? That probably the best combination would be a patella tendon graft with a lateral extraarticular reconstruction, because this combination, the re-rupture rates in his hand is only 2%. So if you were to add an LET in whichever graft you take, whether it is a 4-strand hamstring graft or whether it is a quadriceps tendon graft or it's the patella tendon graft, you'd find that the moment you add LET, the re-rupture rates go on decreasing. The least being in when you do it on a bone patella tendon bone graft. Now, talking about grafts, do you have a myriad grafts that are available? You have the bone patellar tendon, which was the gold standard, or today is again, there is a resurgence of this particular graft, hamstring grafts, quadriceps grafts. We don't have allografts. And there is a new one kid on the block that is known as the peroneus longus graft. So you have various grafts that are available. However, what I want to give you is a simple thing that the re-tear rates of these grafts you'd find are higher in hamstrings as compared to bone patellar tendon bone. So bone patellar tendon bone, if I were to choose a bone patellar tendon bone graft, when would I use it? I would use it in contact athletes. I would use it in sprinters because they want to use their hams to get out of the blocks. I would do them in female athletes because female athletes need their hams, because most female athletes are very quadriceps dominant. And if you take away their hams, then the chances of translation and rupture of ACLs are very high. To me, probably quadriceps tendon is an excellent graft. It has the least morbidity. It has the highest amount of collagen because it is a solid block of collagen. We next come to two very important aspects, what is known as the posterior tibial slope. And if you look at the posterior tibial slopes, you have the mean posterior tibial slopes. In an uninjured control, it was found that this posterior tibial slope was always less than 10. The moment a person had some sort of a non-contact injury, those people were seen to have a slope around 12 degrees, the posterior tibial slope, whereas those who had non-contact bilateral injuries, they had a slope which was 12 degrees above. So posterior cerebral slope of more than 12 degrees, you find that the rupture risk of an ACL is probably almost 60%. And that is the reason why if a person has got a PCL instability, what you need to do is increase the slope. If you have an ACL instability, you should decrease the slope because that itself provides a significant amount of stability to the knee. What is the role of high tibial osteotomy and varus? Now, if a person, so this is when the person has got a sagittal type of deformity. Now, if a person is young, has got medial osteoarthrosis, he also has a deficient ACL, and his symptoms are primarily pain as well as instability, then doing just an ACL reconstruction is not going to overcome his pain. And therefore, this person would be a candidate for a high tibial osteotomy with ACL reconstruction. However, if you have a middle-aged person who then just a high tibial osteotomy is adequate. Finally, if you have an older person who has an ACL deficiency with medial OA, he has pain as well as instability, then probably a high tibial osteotomy combined with a reduction of slope is all that will be required and not an ACL reconstruction. So high tibial osteotomy with reduction of slope, you would use in elderly people. In revisions, a person who's had multiple revisions of his ACL, probably he is a right candidate for reducing that person's slope. The stability, because the slope reduction provides stability without having to do an ACL reconstruction. So to me, a 22-year-old male footballer who has an ACL tear, a ramp tear, and a lateral meniscus root tear would be treated with a quadriceps tendon graft, which is attached with an adjustable loop fixation because that allows me to increase the tension on the graft after fixation, do a ramp repair, a root repair, and a lateral extra-articular reconstruction, not just ACL reconstruction. Thank you.
Okay. So thank you very much, Dr. Narvekar. There was an excellent talk and a great overview of our current methods of practice for ACL reconstruction. Dr. Gawale, would you be comfortable relaying all the talks henceforth? Dr. Gawale?
Dr. Tiku, not Dr. Gawale.
Could you unmute yourself, please? Or should I give it a try again?
Sorry, you are asking me or you are asking Dr. Gawale?
Oh, Agnivesh, you are relaying it?
Yeah, I was relaying it, yeah.
Okay, would you be comfortable relaying the rest of the talks as well?
I think you try once more, otherwise I'll go ahead because I need to control the meeting as well. So you try once, if it's not happening, I'll take it.
I will try once.
Yeah.
Is this seen properly? My video is not there, right?
No, it's not seen. Let me only do it. Just hold on.
So meanwhile, I think we can have question answers going on the YouTube. I'll encourage all the faculty so far to have a look at the YouTube devices, and audience, please feel free to type in your questions right now.
So maybe one question to Dr. Anand Joshi. So can you hear me? Could you please unmute yourself?
I am unmuted.
Yeah. So as compared to your previous practice, maybe about 10 years ago, where a majority of it would have been like meniscectomies, what percentage would you have now shifted to a meniscus repair? And how happy are you with it?
Majority of the patients in whom we do a meniscus repair are those where we do cruciate reconstruction simultaneously. In isolated meniscus lesions, our percentage of repairs is only limited to patients who are probably less than 30 years of age. Whenever they cross or they're in their 40s, I think I'm not too keen on extending my envelope for repair, indications for repair, especially in an isolated meniscus tear. So our incidence of repairs has gone up significantly, and in almost 50% of our ACL reconstructions, we end up doing a repair either on the medial or the lateral meniscus.
Okay, so that's great. About 50% of shift from meniscectomy to a repair,
yes,
and with good results.
On the medial,
so that is
needs to be careful because the failure rates on the medial side are significantly higher than on the lateral side.
Okay. So then, what are the tears that you would prefer to definitely repair, and you would find that there is a least failure rate in those?
So meniscal tears on the medial side, which are associated with ramp lesions, those are my first priority, where I would treat the ramp and the peripheral tear. Also, all longitudinal tears, especially in the red or red-white zone. And I will extend my envelope indication, especially on the lateral side in a young individual, because we know that whenever you do a lateral meniscectomy, the chances of lateral compartment degeneration are extremely high. So you need to, especially in the younger individual with a lateral meniscus tear, I think one needs to go a bit overboard and try and repair them, keeping in mind, of course, that resection may be required later.
Ranjal, we are ready with your talk.
Okay, great. So Agnieszka, we can do the next talk. It is on lateral patellar dislocations, a paradigm shift. Morning, everyone. Coming to lateral patellar dislocations, a paradigm shift. The incidence of lateral patellar dislocations is reported to be 23 per 1 lakh of population. And if we were to narrow it down to a population of 14 to 18 years, it increases to 147. So it is not as uncommon a pathology that we come across in our day-to-day practice. The clinical presentations can vary from symptomatic subluxations to first-time dislocations to episodic or recurrent lateral patellar dislocations to habitual patellar dislocations where the patella dislocates with every flexion extension of the knee. What we are not discussing in this talk today is congenital habitual patellar dislocations and permanent lateral patellar dislocations in adults, as the etiology and pathogenesis is completely different in these conditions, and therefore the concepts of treatment are also different. About 2 decades ago, a lateral retinacular release and medial plication was almost the panacea of treatment for these conditions. The procedures were so common that there were even all arthroscopic techniques developed for lateral releases and medial plications. The aim was to release all the 3 lateral tight retinacular layers and then plicate all the 3 medial layers to achieve a mediolateral balance and therefore restore tracking of the patella. In the past decade to 15 years, however, the understanding and role of medial patellofemoral ligament in patellar instability has increased. We now know that it is the primary passive stabilizer of the patella, providing majority of the medial restraint to lateral dislocations. The results of medial plication fared poorly in most of the cases, with a high rate of recurrence. This was possibly because the MPFL is more commonly injured in its femoral insertion or in the middle third as compared to the patellar end. A plication performed at the patellar end led to a residual abnormal laxity and therefore subluxations, which were more prone to easy redislocations. What is therefore now advocated is an MPFL reconstruction, which is currently the basic procedure for managing lateral patellar dislocations. The role of medial plication being limited possibly to only symptomatic lateral subluxations without any dislocations and have not responded to a conservative line of treatment. Similarly, lateral releases, in fact, as per the current understanding, would be contraindicated in most of the cases, as it actually provides a functional resistance to lateral dislocations by resisting the lateral patellar jump height or distance over the lateral flange of the trochlea. Instead, what is advocated is a lateral retinacular lengthening, where the first and second layers of the lateral retinaculum are incised at different levels and then sutured together to maintain continuity of the lateral structures and therefore lateral stability, at the same time reducing the lateral tightness. That being said, MPFL reconstruction is certainly not a standalone procedure for every case. The approach to treatment has undergone a huge paradigm shift with a very individualized approach to treatment. The clinical assessment is therefore very critical. Apart from the local factors, factors like generalized laxity and abnormalities in the spine, hip, ankle, and foot also should be given due consideration, as they can adversely affect the patellofemoral joint function. In the clinical history, one should look out for dislocations without significant trauma, since these are the cases that are more commonly associated with a multifactorial local etiology and would be more likely requiring procedures more than just an isolated MPFL reconstruction. The presentations can vary from dislocations in extension to dislocations in flexion, as seen here, or there may be dislocations both in extension and flexion. The factors responsible, however, for each of these vary and require accurate assessment and an individualized management. It is especially in the latter two, where the dislocations happen in flexion, that one should look out for femoral anatomical abnormalities. Therefore, we moved on from a simplistic and minimalistic approach of all arthroscopic procedures to a more customized and a holistic approach, where not just an arthroscopic procedure, but multiple procedures or a combination of procedures is required as a primary line of treatment. Amongst the local factors, multifactorial influence of different anatomical factors leading to patellar instability, as well as their effect on clinical outcomes, is now increasingly apparent. Amongst these are the passive stabilizers, including the medial and lateral patellar ligament complexes, the dynamic stabilizers, which include the mediolateral muscle balance, alignment of the quadriceps and the knee, and static stabilizers, including trochlear morphology and the patellofemoral geometry. This has led us to a multimodal treatment concept for this condition, where a bony procedure more often than not is associated with a soft tissue stabilization procedure, following evaluation of all the abnormal parameters. The aim is therefore to address all significant abnormal morphological factors for restoring normal patellofemoral biomechanics to avoid any long-term failures. One should not hesitate to perform a single stage multiple procedure, including bony procedures where they are indicated. An open, aggressive, soft tissue procedure like an insoles medial advancement with an extensive lateral retinacular release, as seen in this case, cannot compensate for a bony malalignment. If these are missed, overlooked, or neglected, it would certainly lead to failure of the procedure. In fact, there is a paradigm shift in the management of first-time dislocations as well, where traditionally a non-operative management has been advocated, except for cases with osteochondral fractures. Those that are having a PISS score of 4 or more have a 5 times higher risk of redislocations than those with a score of 3 or less. Therefore, a primary operative treatment is now advisable for those having a score of 4 or more. With a better understanding of the medial ligament anatomy, we have now come to know of the MPFL as a complex consisting of the medial quadriceps tendon femoral ligament, with a soft tissue attachment onto the vastus intermedius and the medial patellofemoral ligament itself, inserting onto the upper half to 2/3 of the medial border of the patella. A majority of the reconstructions as described in literature have only a bony insertion on the patella and do not address the soft tissue attachment of this anatomy and are therefore not fully anatomic and therefore can compromise the results. Also in the pediatric population with open physis, drilling of bone tunnels in the patella and close to the femoral physis is always avoidable. Implant-related complications can lead to pain and even large bone defects, which could be difficult to revise. As seen in this case of an infection following the MPFL reconstruction using implants, this led to large bone defects in the femur as well as in the patella. What would be therefore more advisable is to use an all soft tissue kind of a technique, like the basket weave technique, what I prefer to use for MPFL reconstruction, which is more fully anatomic due to its soft tissue attachment onto the vastus intermedius. It has a number of advantages besides being anatomical. It allows for differential fixation and tensioning of the two strands of the graft and therefore better physiometric placement of the graft. It allows for better proprioception. It avoids any over constraint of the patellofemoral joint. There are no bone tunnels or implants, therefore the complications are avoided. It can be performed in the skeletally immature and hypoplastic patella. It avoids any radiographic errors. Resurgeries are not difficult and is an economical procedure. The role of medial patellotibial ligament and medial patellomeniscal ligament, however, has not been clearly defined in patellofemoral instability. However, reconstruction of these ligaments is also likely to play an important role in its management in the future. Malalignments are known to be important predisposing factors in lateral patellar instability, and if significant malalignments are not addressed to, then they are likely to be factors responsible for a recurrence. Osteotomies, therefore, are a powerful tool in rectifying these biomechanics and managing patellofemoral dysfunction. The aim of an osteotomy is to achieve a normal hip-knee ankle angle and a quadriceps alignment. Therefore, to normalize the quadriceps vector, have a normal balance of mediolateral retinacular stresses, normalize the patellar tracking throughout the range of motion, and this needs to be done without adversely affecting the patellofemoral joint reaction forces. In the coronal plane, one needs to look out for an increase in the Q angle and a valgus knee, as these are known to be predisposing factors for lateral patellar instability. The Q angle needs to be seen in full extension as well as in flexion, that is the tubercle sulcus angle. In the coronal plane, one needs to look out for valgus alignment, and if we suspect a valgus alignment, it's best to do a scanogram to see the degree of malalignment. An abnormal Q angle is known to adversely affect the lateral patellar shift, and as you can see in this chart, lateral shift is affected right from 20 degrees to even 90 degrees of knee flexion. A valgus positioning is a significant detrimental factor to increasing lateral patellar joint reaction forces and therefore lateral patellar instability as well. A tibial tuberosity osteotomy with medialization is required wherever there is an abnormal Q angle with a tubercle sulcus angle, which contributes significantly to the abnormality. As seen in this example, where there is a J sign that is positive with patella dislocating an extension with an increase in Q angle and a tubercle sulcus angle. A lateralized tibial tuberosity can be confirmed on a superimposition CT scan where a tibial tuberosity trochlear groove distance of 20 millimeters or more is considered to be abnormal. In cases of trochlear dysplasia, however, measuring TTTG distance would not be precise, so therefore one may measure the tibial tuberosity PCL distance instead on an MRI. If this is more than 24 millimeters, it may be considered as significant. However, each of these methods have their own pros and cons as far as the reliability for decision making is concerned. Wherever we plan for an MPFL reconstruction with a tuberosity osteotomy, this can be done through the same incision. The graft is harvested first, followed by the osteotomy, medialization of the tuberosity to the extent that we have planned for, and then fixation using these two cortical screws. A valgus knee needs surgical correction by a varicizing distal femoral osteotomy when the correction required is 10 degrees or more. A preoperative planning should include a scanogram where we check the preoperative mechanical axis. Postoperatively, the mechanical axis needs to go through the center of the knee, so that's the postoperative mechanical axis. When we are planning for a medial closing wedge osteotomy, that is the axis of correction of angulation. Therefore, an arc is drawn from this point to the center of the hip and then extended onto the intersection point to the planned postoperative mechanical axis to give us the degree of correction that we require. In the pediatric age group, the osteotomy can be fixed just using the staples. However, in the adult population, it's best to fix it using a plate and screw device. A lateral opening wedge osteotomy is best avoidable, as this can increase the stresses over the lateral soft tissue structures and therefore can predispose again to recurrence of lateral subluxations. In the sagittal plane, patella alta plays an important role, since the patella remains unstable till higher degrees of flexion till it engages into the trochlea, therefore rendering it unstable in early flexion. Also, trochlear dysplasia with abnormal elevation, spur, bump, or a convexity causes abnormal joint reaction forces along with a non-conforming joint, rendering the patella unstable. Clinically, a patella alta can be easily noticed with the patella facing towards the ceiling with the knee in 90 degrees of knee flexion. If the patella dislocates smoothly and easily with minimal resistance, it should be directing one's attention towards an abnormal trochlear morphology. A tibial tuberosity distalization with or without medialization is selectively indicated in cases of patella alta if the patella remains unstable, primarily due to non-engagement within the trochlea for the first 30 degrees of flexion. The best way to assess patella alta is by checking for patellar engagement in the trochlea, by checking for the sagittal patellotrochlear index, which if less than 0.18 is may be considered as significant. One needs to osteotomize the tuberosity and excise the distal end to the extent of desired distalization. The tuberosity is then fixed distally in the osteotomy. The patellar tendon may be tenodized in the proximal osteotomy site. An abnormal trochlear morphology affects the landing, engagement, conformity, and tracking of the patella. A trochleoplasty is therefore indicated in selective cases where this is a significant factor. As in this case, the trochlea is unable to engage and contain the patella, which remains dislocated in extension as well as in early flexion. Here we see that this patient has an increased tubercle sulcus angle as well. The CT scan shows that there is an increase in lateralization of the tibial tuberosity as well as a convex trochlea, which leads to a laterally dislocated patella. Various types of trochleoplasty have been described in literature. The Albie's lateral facet elevation trochleoplasty may be used in cases with a hypoplastic lateral flange. However, it tends to increase the lateral facetal pressures and therefore is avoidable. A Gutillier's recession trochleoplasty may be used in cases having a trochlear spur or a trochlear bump. A Dijour's sulcus deepening trochleoplasty may be used for a type B or type D trochlear dysplasia. What I prefer to do is a Beriter's type of trochleoplasty, which is more universally applicable for all types of trochlear dysplasia. As seen in this particular case, where a modified Beriter's technique is used with a medial approach instead of the lateral approach, the trochlea is exposed and an osteochondral flap is then elevated from the trochlear area, which is about 5 millimeters in breadth. The undersurface and the bone is reshaped to form a new trochlear groove, and the flexible flap is then sutured back onto it to achieve the new trochlear shape, and therefore this is called as a groove plasty. The tibial tuberosity in this case is medialized to achieve the normal tracking of the patella. Although the procedure may appear to be quite major, in a properly selected case where it is indicated, it does give good results and therefore should not be avoided. A torsional abnormality in the axial plane is an important factor which should not be overlooked. On inspection, one should look out for a negative foot progression angle, that is an in-toeing gait, an excessive hip internal rotation with a shift in the entire arc of rotation, which is suggestive of an excessive femoral torsion. Tibial torsions can be measured by the thigh-foot angle. Torsional abnormalities have multiple and major effects on the patellofemoral instability. These abnormal torsions can lead to an increased lateral vector with an abnormal Q angle. If not, it increases the lateral facetal forces, but also increases the strain over the MPFL complex, all of which predispose to a lateral patellar dislocation. With every excess of 15 degrees of anteversion, it more than doubles the lateral facet pressures. Similarly, the length and strain of MPFL is significantly increased with every 15 degrees of intorsion, even up to 90 degrees of knee flexion. As seen in this case, where the patella dislocates in flexion, this patient has an in-toeing gait, an increased hip internal rotation. However, the tubercle sulcus angle and the Q angle is normal. Here we can see the patella tracks laterally under general anesthesia. The patella is dislocatable laterally, both in flexion as well as in extension. Here is the dislocation in flexion. On a superimposition CT, we can see that there is an excessive femoral anteversion of 34 degrees, which is almost 20 degrees more than normal. So in this situation, a distal femoral derotation osteotomy with an MPFL reconstruction is planned. Here we can see that on the arthroscopic view, there is a lateral tracking of the patella with a huge lateral patellar overhang. A distal femoral osteotomy is then performed through a lateral approach, one K-wire in the proximal, one in the distal fragment, angulated at 20 degrees to each other. The osteotomy is fixed with a plate and screw device, followed by an MPFL reconstruction. Here's the tracking of the patella post-operatively. The hip rotations, as you see, are restored back to normal, and the patella is stable in full extension as well as in flexion with a normal tracking. Excessive tibial torsions, especially in the supratuberosity region with a lateralized tuberosity, needs correction by a derotation osteotomy. This may be performed either above or at the level of the tibial tuberosity. Last but not the least, results of a well-performed surgery can be compromised by a poorly performed physiotherapy and rehabilitation protocol. The therapist, therefore, should be well-versed with the procedures that are performed so as to be able to customize the rehabilitation program appropriately. A few take-home messages. Lateral patellar dislocations usually have multiple underlying predisposing factors, especially those presenting with an insignificant trauma causing the dislocation. An isolated MPFL reconstruction is certainly not the panacea of treatment, and all soft tissue MPFL reconstruction may be a safe and advisable procedure, especially in the pediatric population. An osteotomy is a powerful tool in management of these conditions. It is best to correct all significant abnormalities in the primary surgery itself to avoid any recurrences and long-term failures. Thank you all for your attention. Okay, so from there, I think we can move on to the next talk since we are running a little behind time. We'll move to Dr. Shreyas Gajjar speaking on knee dislocations, what makes the cut in 2021. Agnivesh, could you please relay that talk?
Good morning, everyone. I'm Shreyas Gajjar from Kokilaben Dhirubhai Ambani Hospital. I'd like to thank Ruchita Mehta and the BOS committee for the invitation. My talk is on knee dislocation, what makes the cut in 2021. Knee dislocation refers to complete disruption of the tibiofemoral articulation. It is uncommon yet a devastating injury because of involvement of the blood vessel, nerve, ligament, soft tissue, and bone. Priority is to manage limb-threatening injuries, and functional recovery is dependent on restoration of stability and knee motion. This entity has evolved where 25 years ago it was managed non-surgically in plaster, and early reports indicated reasonable outcome. However, subsequent reports showed a more stable and functional knee with surgical treatment. This was because of advances in graft options, arthroscopic instruments, graft fixation methods, and improved surgical techniques. Also, there was improved understanding of anatomy, biomechanics, ushering in the concept of PCL-based surgical techniques. Knee dislocation is seen in young adults, predominantly males, most often following high-velocity injuries like road traffic accidents, and less often due to sports injuries or simple falls called the ultra-low velocity dislocations seen in the morbidly obese. Kennedy first described a classification based on the displacement of the tibia with respect to the femur into anterior, posterior, medial, lateral, and rotatory. Subsequently, the Schenck classification was introduced, and it is popular and very much in use today. Basically, it classifies knee dislocations in grade 1 to 5 with increasing injuries, and there is a subclassification of arterial and nerve injury. When dealing with a patient with a knee dislocation in the emergency room, it is important to first follow the ATLS protocol, perform a detailed neurovascular evaluation, including capillary refill, assessment of the pulses, all liver limb compartments, and periodic evaluation of the vascularity of the limb. If the knee is unreduced, immediate reduction and subsequently pre and post reduction evaluation and documentation of the neurovascular status is important. The extremity is immobilized in a plaster or a splint, which maintains the reduction, reduces the swelling, and also hopefully improves the neurovascularity of the limb. An external fixator is indicated if the reduction is unstable in presence of a vascular injury requiring vascular repair, open injury, or an unstable knee dislocation because of an associated fracture. Importantly, the external fixator must be applied away from the zone of the injury so as not to interfere with any subsequent soft tissue or fracture fixation. It is important to recognize that 50% of knee dislocations spontaneously reduced when they present to the emergency, and therefore an investigation into the mechanism of injury is important, and also one should look for swelling, ecchymosis, deformity, and presence of wound, thoroughly evaluate the stability and the neurovascular status. X-rays help in ruling out any fractures, and a multidisciplinary approach is mandatory to treat the patient as a whole. Up to 65% of vascular injury has been seen and reported in association with knee dislocation because of the precarious popliteal anatomy in this region. The signs of hard signs of ischemia include the presence of cool cyanotic limb with poor perfusion. The soft signs include a palpable asymmetric pulse with reduced foot warmth. However, one needs to be aware that the signs of ischemia could be masked because of a presence of an intimal injury, and therefore further evaluation in the form of an ankle brachial pressure index or vascular assessment would be mandatory. The ABPI involves the index which measures the systolic blood pressure of the ankle to the upper limb. Less than 0.9 would be suspicious of impeding vascular injury. It is quite sensitive and specific index. However, there are limitations in presence of intimal injuries and pseudoaneurysm, and therefore periodic evaluation is extremely crucial. A CT angiogram in the present day in a suspected vascular injury remains an investigation of choice because of the high percentage of sensitivity and specificity. It is indicated if the ABPI is less than 0.9 in presence of an expanding popliteal hematoma, ultra low velocity injuries in obese patients, high energy, high velocity injuries, and bicruciate injuries. So when we deal with a patient with a suspected vascular injury following a knee dislocation, the first thing is to reduce the knee. If the limb appears well perfused and the pulse is present, along with a ABPI of more than 0.9, then just an overnight observation and serial examination would be indicated. On the other hand, if the ABPI is less than 0.9, a CT angiography is recommended, and it is also done if there is an absent or asymmetric pulse. On the other extreme, the presence of an ischemic limb in the emergency department warrants an immediate transfer to the operation theater, where the vascular surgeon is involved, and typically this involves a vascular bypass to perfuse the limb. The orthopedic team applies the external fixator, and on-table angiography is performed, followed by vascular repair or reconstruction and fasciotomy. The incidence of nerve injury varies from 20 to 45% with lateral-sided injuries. The spectrum involves intraneural damage or discontinuity. The prognosis is worse in presence of a complete palsy at presentation. 85% complete recovery has been reported with partial palsy, and only 38% functional recovery with complete palsy in the up-to-date literature. The treatment options for nerve injury include observation or neurolysis done at the time of the posterolateral reconstruction surgery. However, studies have not shown any difference in performing prophylactic neurolysis versus observation. The other options involve nerve grafting or motor nerve transfer. However, the outcomes are poor if there is more than 6 centimeter gap. Posterior tibial tendon transfers, which were earlier done at the 1-year mark for a non-recovering foot drop, are nowadays recommended early at the 6 months for patients who have a complete palsy with no recovery. So the algorithm for management of a nerve injury with knee dislocation would be that when with early ligament surgery, an end-to-end repair in the form of neurolysis or nerve graft can be performed. It would usually improve the patient's symptoms. If, however, delayed ligament surgery is performed, serial observation with physiotherapy and bracing is important, and one can thereby assess of improvement in symptoms. Baseline EMG studies, if show no conduction, it suggests an exotomesis or a pneumotomesis, which would warrant tendon transfer plus minus nerve exploration and grafting. If the EMG study shows evidence of nerve injury, serial EMGs at 3 to 4 weekly intervals need to be performed. And if there are signs of recovery, it would indicate neuropraxia, which would just warrant serial exams and continue with non-operative management. If, on the other hand, there is persistent functional deficit, then tendon transfer with nerve exploration and grafting need to be carried out. Any associated injuries like distal femur fractures, tibial plateau fractures, bony avulsions of the PCL, fibular head, or Sigon type fractures need to be addressed appropriately. X-rays form the cornerstone of imaging, and MRI remains an important investigation of choice because it allows the assessment of chondral and meniscal injuries. However, the radiologist would be in a better position to refer the MRI accurately if one can do it 24 to 48 hours following the injury once the swelling to some extent reduces. Stress X-rays, which were popular in chronic cases, are becoming increasingly popular even in the acute scenarios when some form of staged treatment is carried out. And it would also help us assess that if there are any tissues which have healed, self-healed, then such extra surgeries would be avoided. So stress views are really in vogue in the present day. Urgent surgery would be indicated if there is an open injury, the presence of an irreducible dislocation which presents like a dimple sign, presence of vascular injury, and compartment syndrome. Operative treatment has significantly shown better functional outcomes over the years with a higher rate of return to work, pre-injury sports activities, with no difference in mean range of motion. Non-operative treatment, on the other hand, would be appropriate for an unfit, frail, sedentary patient or with an isolated collateral injury, and the management involves physiotherapy and using a long-term hinge knee brace. The timing of surgery is based on the ability of the soft tissue to settle. The proponents of early surgery mention the advantages of good soft tissue planes with the possibility of repairing tissues where possible. The downside is the risk of knee stiffness. There is a group of surgeons who believe in a staged procedure where acutely the collaterals are repaired or reconstructed and the cruciates are reconstructed at a later stage. The proponents of delayed treatment advocate this because of a better knee range of motion, and also some tissues would have subsequently healed, thereby reducing the extent of surgery at the delayed stage. However, by delaying the procedure, one risks further meniscal or chondral damage. Late surgery is performed at more than 3 months interval when the scar tissue is settling. However, at this stage, there are less chances of repair and mostly reconstruction needs to be performed. However, because of the complexity of the injury patient characteristics, the literature on the ideal timing of surgery remains unclear and conflicting. Early literature suggested better outcomes with delayed surgery because of a lesser risk of arthrofibrosis. However, in the last several years, recent literature has favored early surgery with improved surgical technique and rehab. Graft usage, namely autografts in the multi-ligament situation, remains challenging, and the choices include ipsilateral and contralateral autografts, and they would be dependent on the extent of the injury, the nature of the surgery, whether it's repair or reconstruction, the preference of the surgeon, and also the surgical technique would dictate the number of autografts to be used. Cruciates are typically reconstructed, and bony avulsions, if present, can be repaired. The medial collateral ligament, on the other hand, can be repaired in the acute situation if deemed so, but requires a reconstruction in the chronic stage. The lateral collateral ligament and the posterolateral corner injuries, both in the acute and the chronic situations, have shown poor results with repair, and therefore only reconstruction is recommended for this type of injury. Knee dislocation surgery presents a number of challenges. Surgeon challenges involve the exhaustion of autografts, the risk of tunnel convergence or blowout, and it is important to have a good multidisciplinary team, especially when one is performing a single stage early surgery, which could last up to 3 to 4 hours. Patient challenges involve a lengthy compliance with brace and rehab to ensure a good outcome. Over a 9.5-year period at Kokilaben Dhirubhai Ambani Hospital, I have treated 24 patients, predominantly males, mostly involved in road traffic accidents. 5 patients had neurovascular injury requiring a major procedure, and they were 3 ligament injuries predominantly, and to a lesser extent 4 and 2 ligament injuries. All ligament surgeries were performed by myself at the early stage, and single stage procedure was conducted. At a 1-year follow-up, the mean functional scores were identical to those reported in the current literature. Overall, the study showed that the younger patients did better than the older ones. I had my share of complications. There were 3 cases of arthrofibrosis, which resolved with intensive physiotherapy and did not require any release. There was 1 case of iatrogenic common peroneal nerve palsy, which self-resolved, being neuropraxia. There were 2 cases of objective residual laxity. However, the patients remained asymptomatic, therefore not warranting any further management. And there was 1 patient which at a 5-year follow-up showed secondary osteoarthritic changes. To take you through some cases, a 3 ligament injury following a road traffic accident. The examination under anesthesia confirms the 3 ligament instability. Firstly, an ACL reconstruction was performed using the ipsilateral semitendinosus tendon. Thereafter, the posterolateral corner and the LCL reconstruction was performed. I commonly use the modified Larson's procedure, and the contralateral semitendinosus was used. The approach involves a curvilinear incision. The first step is to isolate the common peroneal nerve, and subsequently the femoral tunnel in the femoral head is prepared from anterolateral to posterior medially. Thereafter, the semitendinosus graft is railroaded into the fibular tunnel, and it is fixed there with a small biocomposite screw, as seen here. Subsequently, a plane deep to the IT band and the biceps femoris is created to railroad the semitendinosus graft from the fibular side onto the femoral attachment onto the lateral epicondyle. Initially, before railroading, the attachment on the femoral side is prepared, and one needs to be careful that it does not converge with the ACL tunnel. The steps are more or less identical to the fibular head tunnel preparation, and thereafter the graft is railroaded deep to the IT band and the biceps, and subsequently through the fibular tunnel and fixed with a bioscrew in around 30 degrees of extension in neutral position if there is an associated medial injury, or in some degrees of valgus if the medial side is intact. Next, the superficial MCL injury is addressed. A small incision is made proximally over the femoral attachment, and the insertion site of the superficial MCL on the femur is prepared sequentially, as seen here. Thereafter, a plane from the proximal, from the distal to the proximal superficial MCL is created to railroad a graft. In this case, both gracilis were combined. And on the femoral side, the fixation involves anchors. These are quite handy to prevent multiple tunnels and the risk of blowout. And then the graft is railroaded onto the tibial side and fixed in 30 degrees extension. Once again, in neutral rotation in the presence of a lateral sided injury, or in a little degree of varus if the lateral side is intact. It is fixed in situ with a biocomposite anchor, and that's the end result. And post-surgery, EUA confirms a good degree of collateral stability achieved following the open procedure. Another example, a young male who sustained this 3 ligament injury whilst dancing. This was reduced in A&E, and at 2 to 3 week period, an early single stage 3 ligament surgery was performed. Intra-articular ACL and PCL were performed using the ipsilateral and the contralateral semi-T, and the PLC was reconstruction was performed as highlighted in the previous case, as shown in the X-rays here. This is that patient's 1-year follow-up. Examination confirmed that he maintains a good degree of stability at the site of the operated structures. Post-operatively, patients are kept non-weight bearing for a period of 6 weeks. First 3 weeks, the limb is kept in extension. From week 4 to week 6, progressive flexion is allowed. Thereafter, progressive weight bearing is allowed until the 3-month mark. At 3 months, progressive strength training, avoiding any resisted hamstring exercises if there is a PCL surgery involved. And at 6 months, the strength and agility training is allowed. My patients are allowed to return to some form of sports only at 1 year and higher mark, depending on the severity of the injury. The complications seen in my series are identical to those in literature. Importantly, literature has also highlighted that the outcomes are poor in older patients compared to the younger group. To highlight one complication, this is a 29-year-old morbidly obese lady who sustained an ultra low velocity dislocation of her knee whilst walking. There was a 4 ligament injury. This was reduced in A&E, but the knee was very unstable. Also, she had a complete popliteal artery and a peroneal nerve palsy. So she was taken immediately to theatre, and in conjunction with the vascular surgeon, a vascular procedure was performed, and I applied the external fixator as seen in these x-rays below. Unfortunately, the patient developed a significant infection at the site of the vascular procedure, and you can see the VAC dressing tubes in these radiographs here, which took about 3 months to heal, and it ended up in a very bad scarring at the posterior part of the knee, thereby risking further injury to the neurovascular structures if reconstruction was performed. And therefore, in this morbidly obese patient, it was decided to treat the injury non-operatively in a hinge knee brace. A foot drop splint was given to her, and she had achieved around 90 degrees of knee flexion in the injured knee, which was very close to the contralateral normal side, which in view of her obesity was only around 110 degrees of flexion. We keep her under regular follow-up, and these are her radiographs. So the knee is well reduced. However, there is instability, and therefore she needs to wear the brace full time. Repeat MRI showed that there is still high signal intensity in the popliteal area, thereby risking a significant injury and a risk of amputation if a PCL-based multi-ligament surgery is performed. In the chronic situations like a PCL, posterolateral corner instability, bony procedures like an osteotomy as seen here would suffice to treat the ligament instability. However, chronic dislocations remain a real problem and a challenge. So we have significantly evolved in our management of knee dislocations over the last 25 years. Today, we understand that knee dislocation is a multi-systemic injury complex involving a number of structures which influence the management and outcomes. Correct diagnosis and treatment of multiple planes of instability is essential for successful outcomes. The emergency management involves vascular surgery with application of an external fixator, and if necessary, associated nerve surgeries and early tendon transfers to correct the foot drop, because that would also indirectly reduce the risk of subsequent hyperextension in the knee in the presence of a persistent foot drop. The timing of surgery till date remains controversial, but is influenced by associated injuries. Single-stage procedures are becoming increasingly popular due to better rehab protocols. Cruciates need to be reconstructed. Medial side can be repaired, augmented, or reconstructed depending on the nature of the tissue. Lateral side should always be reconstructed because repair has shown poor outcomes. And over the 25 years, the outcomes have significantly improved with better rehab protocols. The future remains interesting with better understanding and further refinement in surgical procedures. Knee kinematics can be improved. Heterogeneity of this patient population, presence of associated injuries, and a wide array of surgical procedures utilized across studies makes comparing clinical and functional outcomes difficult, and prospective comparative studies and randomized controlled trials would help better define optimal treatment strategies for these complex injuries. Thank you very much for your attention.
Okay, so thank you, Shreyas, for that excellent talk. So in interest of time, we'll just quickly move on to the next talk, which is by Dr. Vijay Shetty on Orthobiologics, game changer. Agnivesh, could you please play his talk?
Hi, this is Dr. Vijay Shetty from Powai, Mumbai, and I thank Pranjal and Shreyas for inviting me for this wonderful meeting. Let me share my screen with you. I'm going to be speaking on this topic, which is probably very hot these days. And a lot of people are now looking at what's happening in the field of orthobiologics in orthopedic clinical practice. These are my credentials and these are my disclosures. So it's quite interesting that Shreyas asked me to speak on orthobiologics, a game changer, and that was the topic given to me. But I want to touch on a few things. When you look at the orthobiologic products in orthopedic clinical practice, these are the things that come into your mind. I mean, most of us are aware on bone marrow aspirate, concentrate, which is popularly known as BMAC, and then there is this mesenchymal stem cells, although we like to call them signaling cells these days, and there is the platelet-rich plasma, which I'll be touching more on. And on the other side, you have synthetic products like bone void fillers, synthetic bone, visco supplementation products, and synthetic BMPs. I think most of us are aware that we are looking more and more, looking at more and more of BMAC products, especially for cartilage defects and avascular necrosis of the femoral head. So when you look at the other source of the stem cells, I think this is another very important thing. It even confuses me even today, but I think largely when you look at the fat-derived regenerating cells, we have MAT, that is micro fragmented adipose tissue, there is stromal vascular fraction, and culture expanded adipose derived stem cells, popularly known as ADSCs. I don't have much experience with these products, but I'll be largely touching on the platelet-rich plasma therapy in orthopedic clinical practice. Pretty much everywhere it's being used these days. Shoulder pain, rotator cuff tears. I have some experience with rotator cuff tears. I have done quite a lot of PRP injections on Achilles tendinitis, plantar fasciitis, and the knee. When it comes to platelet-rich plasma, popularly known as PRP, I think most of us are confused. The important thing is that we need to know what are the components of PRP solution. You make a solution and then we need to know what is actually happening with PRP. We have the platelets in a given solution, we have growth factors, we have white cells, we have red cells, and then we have this new kid in town, which is called alpha-2 macroglobulin. So when I started PRP in the year 2009, I had to go down to Los Angeles and look at how they prepare, and things have changed ever since. So when you are looking at a solution, there are so many factors in a given solution of platelet-rich plasma. Not all of them are good for the body. There are ones which are good for the cartilages, and there are the ones which are actually not good for uh, chondrogenesis. And the one on your right side, the right photograph where you see the names in yellow are not good. This is a very important slide courtesy Jason Ragu from Stanford. Now, why this is important is this was not known about 10 years ago. And now what's happening is that we need to know what factors are not good in that given solution, and we have to ultimately eliminate them. Before I start my lecture, I want to make sure that my younger colleagues are aware or know that this should not be our first line of treatment in a given clinical practice. Now, why then it's important? If you are looking at any condition, for example, early osteoarthritis of the knee or a ligament injury, we go through a treatment spectrum, and the treatment spectrum starts with what's called non-operative or conservative treatment. Whenever you see a patient, you look at him or her and start doing a non-operative treatment initially, unless it's really demanding. And then on the other end of the spectrum, you have what's called operative option, where surgery is recommended. So I think when you're looking at this spectrum, there is a definite um, uh, role for platelet-rich plasma, especially in some conditions which I'll be touching on. I think this is where we are at the moment. And so just before going under the knife, I think it's very, very, very important that, if there is an opportunity, we should be considering uh, platelet-rich plasma. So I think there's so much debate about the type of preparation that we make for before injection. For me, at the moment, I think when I'm teaching my fellows and students, I tell them there are two very, very important solutions, two classifications. The PRP that's rich in white cells and the PRP that's poor in white cells. I think these two preparations are very, very important depending on what you're doing. This is truly indication specific. In my practice, these are the conditions I generally deal with when it comes to PRP. Remember, again, I said that it's about treating these conditions which are recalcitrant. For example, plantar fasciitis. I've been doing this for now almost 10 years, and I probably have the best experience for plantar fasciitis in respect to PRP. And it's definitely not the first line of treatment. So when you're looking at these conditions, there's ankle sprain, especially in sports medicine, patellar tendinopathy, Achilles tendinopathy, rotator cuff, tennis elbow, and I think most importantly, the early, very, very early OA of the knee in young people. PRP is also used to augment some sports surgeries, especially after ACL reconstruction. And of late, we are getting more and more reports of the use of PRP in non-unions of fractures. Now, if you are looking, if you go through PubMed, and if you look at the literature for PRP in general, this was done about 6-7 months back, and you see in 1954 there were nothing, and in 2020 there are almost about 12,000 publications in PRP. And when you then go back to PRP in orthopedics, again, it's nearly 2,000 now publications for PRP. And PRP in sports medicine, I think, has actually gained a lot of importance of late. And especially in 2015, when some of the very, very prominent sportsmen, elite athletes received PRP injections and returned back to their sports. PRP became very, very popular in the social media, in news, in print, and everywhere. I just want to touch on these common conditions that we treat. The idea is to let you know what is the evidence that we have at the moment for ankle sprain, especially one of the commonest sporting injuries. Almost 15% of all sports injuries are ankle sprains or ankle injuries. I don't think at this point there is any evidence to support the use of PRP for acute or chronic ankle sprains. The next commonest condition is patellar tendinopathy, or in some cases we use the word jumper's knee. Again, when I looked at the evidence, this is Jason Dragu's paper in 2014, and we have 2 level 1 studies so far, and unfortunately it's a comparative study, and comparing PRP to dry needling and extracorporeal shortwave therapy. And both the studies show PRP doing better, but in small groups. It's not really convincing. Achilles tendinopathy, again, I'm not sure. I mean, this depends on your practice, how long you've been in practice, and whether you've had enough experience with the injection. And at the moment for Achilles tendinopathy, PRP, as far as evidence goes, it's not recommended. I have had some personal experience with partial tear of rotator cuff. In fact, I injected a close friend of mine who lives in the Middle East and came over, and some other friends. And obviously, over a year, I've seen the difference, the supraspinatus muscle strength coming back, and they escaped the surgery. But this is a personal experience, and the problem with literature for rotator cuff is so far we have got no evidence, no studies showing direct injection into the tendon. As we are all aware that when you want to inject the shoulder, it's usually the subacromial space. But I think that evidence is missing in the literature at the moment, where we need to identify the tear of the tendon and inject. Again, there was a level 1 study last year showing that PRP has not been useful in rotator cuff tendinopathy. In plantar fasciitis, this is my favorite topic. I have been using this for the last, since the year 2009. I've got more than 150 patients, and I'm thoroughly impressed. In fact, if I have someone at home or in the family, in my own family, who is suffering with plantar fasciitis, recalcitrant plantar fasciitis, I would definitely encourage them to take PRP injection for the same. And we published this back in some time back, and comparing the results between steroid and corticosteroid and PRP and our group. Our study clearly showed that the PRP group did much better with respect to pain scale and foot and ankle score. I think at the moment, as far as tennis elbow is concerned, we have the best evidence available. And obviously, I mentioned earlier that the tennis elbow, and this is the tendon issue, so we should be actually talking about leukocyte-rich plasma for the tendons. I'll touch on that again a little bit later. So in football, hamstring injury is very common, and there are some people who've been injecting on hamstrings, but at the moment we have inconclusive evidence. There is a paper recently from London showing that stating that PRP is being useful, but we still don't have level 1 or 2 studies on hamstring injuries. I think this is the main thing on the osteoarthritis. And when Shreyas asked me to speak on orthobiologics, I thought I should stress on the knee first, because it's the most important topic, and we are still struggling when there is a problem with problem in the knee in the youngsters. If you're really looking at the use of orthobiologics or PRP in early OA of the knee, you see the last 5-6 years, there's been a number of publications. I want you to, this is a busy slide, but I want you to follow this column here. You see, these are all, type 1, almost all of them except one. They're all level 1 studies here. And look at this column. You see leukocyte-rich PRP, and that is this is intra-articular injection of the knee. And again, you see leukocyte-poor PRP, it's plus, there is good result. Leukocyte-poor PRP, there is a good result here as well, and leukocyte poor. So what does that mean? This means that if it's an intra-articular injection, it has to be leukocyte poor PRP. This is one resource I encourage all my younger colleagues to follow. Just log in or become a member of Ortho Evidence, which is managed by Dr. Mohit Bhandari from Canada. And in my opinion, this is probably one of the best resources when you're struggling for evidence. So what they've done just about 2 years ago is that they have compared PRP to placebo PRP for non-operative in terms of knee arthritis or early knee OA, placebo, non-operative treatment, steroid, hyaluronic acid, and surgery alone. And you see the trials, we have the large number of trials, PRP with hyaluronic acid, which is interesting. I'll again touch on that a little bit later. So, so their conclusion is that PRP has been doing well, except that when it's surgery, I guess this is probably arthroscopic debridement of the knee, where it's not done that well, but otherwise PRP has done well in other scenario in respect to hyaluronic acid, steroid, non-operative, which is physiotherapy and other non-operative modes, and obviously with placebo, which is saline. So if you are looking at this paper, this is 2020, last year, early OA of the knee, level 1 study. They found 18 level 1 studies, mean follow-up almost a year. PRP group did much better in terms of VAS, OMAC, and IKDC. And leukocyte poor PRP, in their opinion, has actually performed much better. I'm aware of a recent study from Chandigarh where they've compared leukocyte rich and poor, but I personally feel that we should, when it comes to a joint, we should still think about leukocyte poor PRP. Then I thought it's quite interesting to see, because I worked for some years in the UK, and the UK regulatory body for clinical practice, that is NICE, National Institute of Clinical Excellence, which recommends any new treatment. So I went on their website and checked whether what's the current recommendation, which is very important for us to know. So as far as safety is concerned, there are no major concerns. As far as efficacy is concerned, there's limited evidence. And so they recommend that if you want to use PRP in your clinical practice, You have to sit with the patient, talk to them properly, inform them, and get a fully informed consent. Yes, so PRP for tennis elbow, I think it's still good. For early OA of the knee, it's good. So patellar tendinopathy, we're still struggling for evidence. Plantar fasciitis, level 1 study is missing. And rest of them, rotator cuff, ankle sprain, muscle injuries, I think you'll have to actually be sitting with the patient and then um, take informed consent and offer the treatment. The beauty of this treatment is that so far we have had no evidence of any disastrous side effects or adverse events following the injection. So what's new in orthobiologics? I think this is a new kid in town. Bill Murrell from the Middle East has published a nice paper recently. In fact, he did a presentation in Mumbai in one of our conferences. This is autologous gold-induced cytokine therapy, which is supposed to be very promising in early osteoarthritis of the knee. This is interesting. I think there was a time when we were comparing hyaluronic acid and leukocyte PRP for early osteoarthritis of the knee. Of late, we're seeing more and more preparations coming, combined preparations with HA on one tray and then leukocyte PRP, which has to be prepared. And I've had no experience, but I think we are moving forward in this direction for early osteoarthritis of the knee. So the take-home message, the answer to the question, is that a game changer? I think in a way it is, because we have actually changed the way that we treat young knee osteoarthritis problems. But again, this is still, I think we have to remember that it's not the first line of treatment. And since we are talking more about knee, we have to remember that there are some basic principles we still follow. We have to make sure that the alignment is right. We make sure that deal with the cartilage and the ligaments, all that, and then look at these options. So as far as the safety is concerned, we are very clear now that it is a safe alternative or a safe option. Efficacy, it's indication specific, as I mentioned to you. I think for tennis elbow, there's good evidence. There's you can give this injection with closed eyes and early osteoarthritis of the knee in young people. Yes, we have to make sure that our patients understand what we're doing to them and what is the logic behind this treatment. And when it comes to the joints, I still think that we should be sticking to leukocyte poor PRP. We have special kits now which actually prepare leukocyte poor PRP. And when it comes to soft tissues, it is definitely leukocyte-rich PRP. I thank you for your attention. If you have any queries, you can please email me at vijaydishetty@gmail.com. Thank you very much. Have a good day. Bye.
Okay, so thank you, Dr. Vijay Shetty, for that talk. We are running a little behind time, so there is a little change in the program. We'll first have the BOS announcements by Dr. Rujita Mehta, and this will be followed by our case discussions. So over to you, Rujita. Can you please unmute?
Secretary Dr. Swapnil Kenny will be making the announcements. I'll take over the session after that.
Okay.
Good morning, dear members of the Bombay Orthopedic Society. Unfortunately, it is my painful duty to announce yet another obituary. And since the time we've started this academic year, this is the third obituary in the third program which we are doing. And today it is about somebody who was from Mumbai, a teacher, a mentor, a colleague, a guide to many people whom we know and many of us here. I'm speaking about Professor Dr. Ravindraji Khedekar, who passed away on the 13th of June 2021 after a prolonged illness. Dr. Khedekar was a senior member of the Bombay Orthopedic Society. He did his MBBS and MS Orthopedics from the TN Medical College in Mumbai. He worked as a lecturer at the Sion Hospital for many years, was a senior consultant at Chembur and practiced till his end days. But what was his passion was teaching orthopedics. He joined the D.Y. Patil Hospital in 1992 as a professor and served there till almost 2 years ago. He was also the head of Department of Orthopedics at the D.Y. Patil Hospital for nearly 5 years. Known as a strict disciplinarian with a passion to teach undergraduates and postgraduates, and many of us here have heard his lectures, interacted with Sir, and been a part of his teaching. He has mentored and nurtured generations of orthopedic surgeons. May I request all members for a minute of silence in the memory of his departed soul. Thank you very much. The second part of this break is about the announcements. And I'm very happy to announce that we are back to the time when the instructional courses of the BOS have been announced 2 weeks back. And we start in the next month. So we are a month away from starting all the BOS instructional courses. This year, the courses are online and we have an array of 16 courses to offer, which include the orthopedic oncology course, osteotomies around the pediatric and adolescent hip, the hand surgery course, basic arthroplasty course, research methodology course, the JES course, fracture fixation course, advanced foot and ankle, BOS basic spine course, the pelviacetabular course, BOS basic arthroplasty course, technology skills course, basic Elizarov course, basic pediatric orthopedic course, a course on orthopedic implants, and a course on musculoskeletal radiology for orthopedic surgeons and radiologists. You can subscribe to these courses. They are all online on www.bombayorth.in. These are reasonably priced, and if you're a member of the Bombay Orthopedic Society, you get a further discount. So I would request and recommend everybody who's watching this webinar on YouTube to kindly go to the website and subscribe these courses. We shall also be sending you periodic reminders about all our courses so that you can subscribe to them easily. Thank you very much. With this, I hand over the proceedings again to Dr. Rujuta Mehta.
So it's been a very lovely in-depth session in the knee. I think it's opened our eyes that, just when you say the term IDK, there is a lot that goes on inside. and what are the newer approaches now to handling them. We have a lovely shoulder session as well, but we'll take the pending cases from the first session and then roll over to the shoulder immediately. Pranjal, Shreyas will be taking over part 2.
Yes. All the faculty here will be involved in the discussions. We will try to make it as quickly as possible so that we can stay on time.
Please start the cases. And again, all panelists, please switch off audio and video except the speaker.
Is my video off?
Yes, you can. Your screen is visible. You can go ahead.
Okay, so this is one case, 19-year-old female who came with bilateral knee instability. She has a past history of having a progressive valgus in both the knees since she was 3 years of age. She was under observation and care of a senior pediatric orthopedic surgeon since she was 10 years of age and was diagnosed to have epiphyseal growth arrest, unknown etiology. At 12 years, she had a valgus flexion deformity in both the knees and could not walk without support. So he had performed a bilateral distal femoral corrective osteotomy with a medial hemiepiphysodesis. When she came at 19 years, she was then referred to me with right knee instability and inability to negotiate stairs without support. She had recurrent dislocations of the patella and clicking. As you can see, this was her alignment view. Alignment was good. And on examination, she had full range of movement. There was no local tenderness anywhere. Her patella was dislocatable laterally as well as medially. And she had a global instability of grade 3 laxity on medial, lateral, anterior, as well as posterior, and a rotatory instability with a dial test of 70 degrees. So she came with these stress views that were done. So I did an MRI just to rule out any intra-articular abnormality like a meniscus tear or any chondral lesions. And as you can see over here, the menisci appear to be fairly normal. If you see the notch area, there is just a little remnant of the ACL and the PCL. The major thing is she has a very narrow notch over here, and you can see that there is a lateral femoral condylar hyperplasia. So I did a CT scan. So these are her pictures, the axial films. These are the coronal films and the sagittal ones. I went ahead with a 3D reconstruction, and as you can see over here, there is a lateral femoral condylar hyperplasia, which you see there, and a trochlear dysplasia with a hypoplastic notch, very narrow notch over there. Now, in this situation, she comes with high expectations. What should we do in this scenario? Possibly the management options are just bracing and restricting her activities, defer possibly the surgery till she develops pain, and then maybe advise a knee replacement or an arthrodesis? Or should we advise her a surgical stabilization by ligament reconstruction at this stage? Or if anyone else on the panel feels that any other option can be given to her. So this is now open to discussion. Anyone would like to take up the case?
You can have your videos on now. Maybe you could choose a faculty and ask them pointedly, Pranjal.
So Shreyas, would you like to start?
Yeah, so Pranjal, it is a complex situation, and currently I would just kind of await what the the expectations and the requirements of the patient are. A trial of bracing and restriction of activities would certainly be an option, but being symptomatic, I would consider a surgical stabilization with ligament reconstruction, bearing in mind that this is going to be an extensive venture.
So we would opt for a surgical procedure for her at this stage.
Yeah, I've discussed with the patient, and yeah, possibly, yes.
Okay. Bhushan?
So there seems to be a significant lateral femoral condylar hypoplasia, which seems to be the culprit in most of her instability as such. So I think ligament reconstruction, it will be too much to ask for a few strands of ligaments to support a badly unstable knee. I think a bony procedure which involves recreating the lateral femoral condyle will work better. You can do an intra-articular osteotomy and elevate, or rather reposition the lateral femoral condyle where it should be with some bone graft. If finances are not an issue, you can actually do an allograft transplant as well. But I think that's not feasible in India. So an osteotomy with elevation or increasing the size of the femoral condyle with some bone graft and a lateral plating would be something I would consider. But it is
so
a very
over here we saw the alignment is normal. Her primary complaint she's coming with is instability and patellar dislocations and unable to walk without support. So going up and down stairs is difficult for her. You think this procedure would help her?
So if you look at the stress views, there is significant defect or significant opening of the lateral compartment, and which is probably due to the lateral femoral condylar hypoplasia. I think that that is something that needs to be addressed before we think of a ligament reconstruction.
With the alignment view being normal, you would still advocate that.
Yeah,
all right. Dr. Narvekar, would you have an opinion on this? Dr. Narvekar, could you please unmute yourself?
I would definitely not do any surgical stabilization of ligament reconstruction. With an abnormal looking condyles, there is no question of any ligament reconstruction providing type of stability. This instability is entirely bony, and therefore I would refer to somebody like you or Bhushan to assess and find out what is bony deformity that needs to be corrected. Definitely no ligament reconstruction on my part.
Okay, Vijay Shetty is raising his hand. You can unmute yourself and then speak.
Pranjal, I like your. Can you hear me?
Yes, we can.
Yeah, I like your last slide. This. She's 19, isn't it?
Sorry, she's 19 years old. That's correct.
So the last slide. I totally agree with Abhay. A 19-year-old restriction of activities, probably current day and age, probably not acceptable. So that there comes a point where I think I should actually involve some colleagues to, I don't know really the answer to this, but I would probably, it's totally acceptable to accept that I don't know what to do. And I would probably involve some senior surgeons who are experts in that field. So in my own opinion, restriction of activities in a 19-year-old girl is not acceptable.
All right. Dr. Joshi, would you like to comment? Dr. Anand Joshi?
So Pranjal, I agree totally with Abhay and both Bhushan that soft tissue procedures are not going to work in this situation where the bony alignment is the primary issue. And
sir, alignment view is normal. It's showing a normal alignment.
But there is loss of bone, like Bhushan said, on the lateral condyle. So even if you do any soft tissue procedure, it is unlikely to work for a prolonged period of time. I have seen that majority of the soft tissue procedures tend to fail at 1 or 2 years and give you very short-term results, and therefore some bony procedure needs to be done before considering any soft tissue procedure.
Okay. Would Dr. Sanjay Desai like to come in?
Yeah, Pranjal, I need to know whether this girl's symptoms are from patellar instability or tibiofemoral instability, and is pain also a component?
Pain is not an issue. It's primarily instability. She's unable to go up and down stairs, and sometimes she buckles while she's walking, and she has got clicking. She has patellofemoral instability as well as tibiofemoral instability.
Yeah.
Both are the reason for instability.
Yeah. So, therefore, I think looking at the X-rays and CT that you showed, I will counsel the patient that no matter what we do today, this girl is going to end up with some form of either arthrodesis or alternative surgeries in the relatively near future, no matter what you do just now. I already see some evidence of secondary arthritis in the knee, flattening of the condyles I noticed. So therefore, I will be very guarded on offering any form of surgical treatment. If possible, continue with conservative treatment and tell the patient that you will need perhaps an arthrodesis or I don't know about arthroplasty, depending on when she comes on the table.
Okay, so the second option is what you would take. Is there anyone else who would like to opine? Okay, so this is what her examination finding was. We thought of going ahead with a surgical ligament stabilization, which possibly we thought would work. In fact, when we tried to dislocate it medially, it was locking medially. That was her Latchman test. You can see there is a posterior sag, and she had a pivot shift which was positive. That is the post-Latchman Roberts test. And then this was the pivot shift, 70 degrees. And that was the varus valgus laxity that she presented with. So now, for those who said that possibly ligament reconstructions to be done, which structures would you reconstruct? What graft would be your choice? What would be your fixation? And what could be your expected prognosis? I think Shreyas, you opted for it, right?
As mentioned by the panelists, the prognosis is guarded. This is not a simple scenario which you encounter in your day-to-day practice. As far as the grafts go, gracilis is my go-to graft for the medial side, and it depends on what sort of stability is achieved. But also, when we say surgery, it would also amount to some bony correction as well, if required. And that decision would be taken based on what kind of stability is achieved. Taking it step by step. So the hamstrings would be my go-to options for this type of procedure. Fixation, I tend to use anchors, biodegradable. The post-op rehab and expected prognosis I've already kind of highlighted on. Rehab would depend on what is the extent of the surgery. Obviously, the patient needs some form of bracing in the early post-op period to protect the reconstruction.
Okay. So just in interest of time, we won't go into the details of how we would reconstruct. I'll just try and rush through the case because we have a nice case lined up by Bhushan next. So what I prefer to do is do a multiple ligament reconstruction and stabilize the knee. I reconstructed the superficial MCL, the deep MCL, posterior oblique ligament, a Larsen sling reconstruction on the lateral side with a popliteus sling reconstruction. The graft choice for me, I needed to harvest semitendinosus and gracilis from both the knees. And fixation was using interference screws and ligament staples. This was her arthroscopic picture. Here you can see that there is a trochlear dysplasia, a V-shaped trochlea, a sharp patellar ridge, as you see over there. Then we move on to the medial side. Here you can see that there was a grade 3 opening on the medial side. There was no chondral defects or any abnormality with the cartilage. On the lateral side, you see that there is a robust popliteus with an attachment over there, but a grade 3 laxity on the lateral side. If you go to see the ACL and the PCL, it's just a thin remnant, flimsy remnant over there, both the ACL and the PCL, so hardly functional. So this is what I did. That's the screw on the medial side for the superficial MCL and the deep MCL with the posterior oblique ligament over there and the MPFL. So this screw would be holding all the ligaments on the medial side. This is the screw for the popliteus, which would hold the double gracilis going there. And this is for the Larson's sling reconstruction along with the ALL. So this was the immediate post-op. You can see the patella was well stabilized. That was a dial test reduced to 30 degrees. That was the Latchman, well stabilized anteroposteriorly, the Drawers test. This is immediate post-operatively, as you can see. And this is the varus valgus stability that we could achieve. So she's followed up with me now. This is 5 years post-operatively. She can walk well without support. She can go up and down the stairs well without support. And this is her examination finding. So this is 5 years post-operatively. She has a good straight leg raising, full range of motion there. Her patella is well stabilized, both medially and laterally. That is the drawers anteriorly and posteriorly, good stability. That is the varus valgus, reasonably well stabilized in extension and in 30 degrees of flexion. And that is the posterolateral drawer. This is normal, and the pivot shift is negative. So possibly extra-articular reconstructions also play an important role in knee instability, not just the intra-articular reconstructions. It provides mediolateral, rotatory, as well as anteroposterior stability to the knee. So it's important to consider these factors, I think, and not just focus on the intra-articular reconstructions. Possibly that could be the take-home message from this case. Any comments?
Pranjal, do you have the MRI pictures just now?
Yes.
Of her knee?
Yes.
Post-op?
Post-op?
Yeah.
No, post-op I have not done the MRI.
Because you'd like to know what is the status of all the ligaments that you have reconstructed. In the presence of an abnormal, movement in terms of shape of the condyles, you don't know how the ligaments can survive. Stresses on the ligaments are going to be eccentric. So it would be interesting. It's a very good result. It would be very interesting to see what has happened to those reconstructed ligaments.
Sure, maybe, but we've not done an MRI on her right knee. In fact, she followed up after that. She had, as I said, instability on the other knee as well, with the same problem. And we managed the other side as well at about, I think, 3 years following her right side surgery. So she was pretty confident about getting back to normal even on the other side. And because I had harvested grafts from both the knees for the first side, I needed to ask for allografts on the other side. So this is her result, what I showed you just maybe about a week or 10 days back. The videos were just taken about 10 days back. So she's 5 years post-op and she has no pain and she has no complaints of instability and she's walking without a brace as of now.
So Pranjal, in this kind of extensive surgeries, how long do you protect the reconstructions in a brace?
Yeah, so she was protected in a rigid long knee brace for 6 weeks. I did start a range of movement at about 3 weeks or 4 weeks, as far as I remember. Of course, the VMO, straight leg raises, calves, and all those start immediate post-operatively. I needed to put her in a good hinge knee brace after she was off the rigid long knee brace. She was also non-weight bearing for the initial 1.5 months. She was using a walker or crutch. She got her full movements by about 2 or 2.5 months.
Okay. Yes, Dr. Desai.
Pranjal, are you surprised with the result or did you expect this result?
Of course, you cannot expect a result because this is something that is very unusual. And I had told her that we cannot assure you any results. But looking at the results post-operatively, I was pretty happy at it, and so was she. And so she opted for the other knee as well. And we did the same procedures on the other knee, but using allografts.
Okay. And how long follow-up do you have on the ones with the allograft? Because that will be interesting. Autographs, allograft.
That is just about 2 years or 3 years. But the results of an allograft, as far as the lateral side was concerned, I'm not very happy with it. But the rest of the stability was very good as compared to the right side, which I showed you right now. The left side with allografts did show some amount of loosening on the lateral side.
Okay, great, Pranjal. If you're okay, then we can move on to the next case. Thank you.
Yes. So the next case is by Bhushan.
Okay, I'll start sharing my screen.
Yes, so I'll just stop screen share.
Okay, so I hope you can see my screen. So after such a complex case from Pranjal, I'm going to show a very simple case for discussion here. So this is again a typical patellar dislocation patient, 14-year-old chap who comes with the first episode of patellar dislocation. It was a proper traumatic event when he was running around when someone bumped into him and he felt his patella come out. It reduced spontaneously, but this was associated with a fairly significant hemarthrosis. And this is how he came to us. This is not his picture. This is just a representative picture. So he came with a significant hemarthrosis, and he was already seen by one of the orthopedic surgeons who advised just a strapping, a knee support, and not to go for an MRI scan. So as a rule, in children or other, for anyone with a patellar dislocation, it's important to get an MRI scan for the simple reason that something like this can be lurking in the knee joint. I know this is a very small picture, so let's magnify it. And what you can see is the big patellar chondral defect in the medial femoral condyle, and that corresponding big piece is sitting in the lateral parapatellar gutta. Same thing can be also seen in the coronal sections, as you can see here. So now we are faced with an issue of a relatively large, rather whole of the medial patellar chondral facet sitting in the joint. So an arthroscopy was performed to assess the joint. First 3 minutes are just washing out the knee because you can't see anything. It's all blood there. I'll just fast forward it to the relevant part of the arthroscopy. So in the lateral parapatellar gutta, this was seen. This is 1.5 by 1 centimeter sized, punched out, kind of a punched out lesion, kind of a fragment sitting in the lateral parapatellar gutta. Again, a bit more washing out to see what we're dealing with. And this is what the fragment looked like. It's still fairly early, less than a week from the injury. So it's still not got synovialized, still not got attached. The rest of the joint was fine. There is a corresponding, there is also a lateral femoral condyle impact injury, as you saw there. And on the patella, there is a corresponding defect where the fragment came out from. So the question is what to do with this fragment. Should we do something? I think Pranjal has already shown a case of his where the treatment was already discussed, so I won't waste too much of time. But that's how the fragment is. There is absolutely no bony component to the fragment. It's purely cartilaginous. And you can see the fragment is being held by a grasper. And just to confirm that it's coming from the patellar crater as such. Now, the options in front of us for a 14-year-old, remember, is remove the fragment and leave the crater to fill naturally. The body will do its own BMAC and heal or fill the defect with something, or remove the fragment now, discard it, and come back later to do a BMAC or a stem cells or oats or a mosaic in future, or fix the fragment with screws or bio screws or bio darts, which is not feasible, I think, in this because of there is absolutely no bone to the fragment. Now, if there is a good bone, you can always use a headless compression screws. But I think this fragment, can it be salvaged? Rather, can it be not put in the bin and put back onto the patella and fixed? Pranjal, you can't speak because you've already shown the case. I think everybody knows the answer. So any takers for how to fix this fragment? Will anyone glue the fragment back or do anything else? So Shreyas?
So yeah, this is a common scenario. Now, having done the arthroscopy, I will remove the loose body arthroscopically, and then I will do a medial parapatellar incision, and I will assess whether I can fix this loose body. From what you're telling me, it appears that it might be difficult, in which case I have done the BMAC procedure primarily. I wouldn't just leave it to heal on its own naturally.
Okay. Dr. Desai, do you want to say anything about this?
Yeah, my first choice will be to make an attempt after finishing the arthroscopic job through a mini open, try to suture this piece. I have done it on 1 or 2 occasions when there is no bony component to this piece. It is purely cartilaginous. It can be a challenge, but you can still suture it sometimes.
Okay, so
often if it is very soft and friable, then you can't. And if that is the situation, I will send that piece for stem cell and second stage ACI.
So both of you guessed the answer, right?
And rest assured, when you send this sample for ACI, you'll be surprised that a large number of patients will not come back.
That's true. That's absolutely true.
Which is why we said BMAC. So, on the same stage, you do both procedures.
No, so I said we will try and fix the fragment. If you are not able to, then you will do something else. So this was the fragment in question. There was no bony component to it. Again, a medial parapatellar approach was seen, and you can see a well clot-filled crater corresponding to the size. Now, what procedure was done was actually fixation of this with suture technique. Let me just get this video running. So as you can see that you need to clear the crater completely. So we just cleaning the base of the crater. What you will find that the fragment swells up quite a bit inside the knee joint, and quite a few times it's difficult to fix the fragment back because the fragment becomes too large. And that's mainly because of swelling of the fragment as well as the filling of crater that happens. So make sure you do multiple drill holes in the subchondral bone plate. This will be a very tough bone. So you need to make sure ample blood supply can reach this fragment and allow some form of healing. Now there's a bit of fiddle involved in getting that fragment back into its normal position. Quite a few times when you're trying to push it, the fragment can just bounce off and land on the floor. So if you see Sajir, our assistant here, is going to lift his dress up to make sure that there is some cover so that the fragment won't bounce off. That will be a disaster if that happens. So you need to find a perfect position. It's like fitting a jigsaw puzzle. You need to see the lines on the cartilage and where that fragment is going to fit into the original position. Once you've got the fragment fixed, just put a central K-wire to hold the fragment back. Now it's important to elevate the layer superficial to the patellar periosteum where the prepatellar bursa is, and clear the area to retrieve your sutures for fixation. What we have found is that if you use a straight needle as a drill or as a K-wire, it works quite well, and it helps you fixation of this fragment much easy. Now, there are various ways and various configuration described for fixation of this. So what I think is multiple V-shaped fixations, as you will see, in which the sutures are overlapping, gives the best secure fixation. Now, we have a series of about 9 of these patients in last 4 years. And what we have learned, of course, through our normal mistakes is that it's better to go for Vicryl rather than go for a non-absorbable suture such as Ethibond or fiber wire. because what we find is that fiber wire and tends to cheese wire through it, and ethibond has a high chance of causing significant scarring inside the joint. So simple vicryl suture is passed such as this and retrieved from the other side. And this procedure is repeated multiple times. Each time the sutures are retrieved in the created space plane proximal to the superficial to the patellar periosteum. And once you've done this a few times, now you have now got an array of sutures which are supporting the fragment, and you can get rid of the central K wire and use that hole as well for fixation of this fragment. So ultimately you are looking at fixation of this fragment in such a way. We have toyed with the idea of using a tape, a suture tape or a fiber tape, but a vicryl tape would be better. But I've just used a simple vicryl suture for the worry that I might cut through the fragment or might cause fragmentation of the fragment, as was mentioned. So once you've done this a few times, you have got a good fixation of the fracture fragment. Sorry, give me a second. Now, tying these sutures is slightly difficult because you're tying at a depth. You need a good assistant who will hold the patella everted while you're doing this. It's again a good trick to release the fat pad or the fat layer which covers the patellar tendon to allow you to evert the patella well. And that's the final result, where you have seen multiple V-shaped configurations to hold the fragment. And the fragment, you'll be surprised to see, is very malleable, and you can easily fix it perfectly the way it came from without cutting or reducing the fragment size in any way. In younger patients such as 14, I would just do a medial plication and get the patella stable, and that works mostly in these patients because there is no bony deformity here. Since you have replaced the fragment, there is less chance of it slipping out. But for seniors, this was a 21-year-old patient with again the same injury. You can add an MPFL. I use anchors for my MPFL, and you will find there's plenty of space to put your anchors. And you can do a normal MPFL on top, go between the layer 2 and 3, and fix the fragment with a screw. And that's roughly how it looks. This is a different patient, but you can see a small bony sliver that was still there. I still feel this is too small for fixation with screws in any way. And these are a couple more patients that we have done. So we got a series of 8 or 9 who have done really well. I think one patient who was treated with ethibond needed an arthrolysis postoperatively because she became quite stiff. But so this I think is a very good idea to get out of a problem of a purely cartilaginous patellar fragment sitting in the joint when you're scoping a patient with a patellar dislocation. I think I won't go to the next case. We'll stop here. We're running late.
Yes. I just do a small comment.
Yeah.
Bhushan, nice case. I did one last week. Actually, he's a relative of one of my close friends from Kerala. So I used the Arthrex, the absorbable K-wire. Obviously, that was a osteochondral defect. It was, quite thick. There was a chunk of bone as well.
Yeah.
And so it was, it fitted well. But I agree with you. I think if you leave it for more than 4 or 5 days, it swells up and you end up trimming the edges and then sort of fit it in. Yes.
Yeah.
Okay.
And then I did an MPFL repair as well at the same time.
Yeah.
Right. So since we are running quite a bit behind time, let's try and cut this knee session over here. And thanks to all the faculty involved in this knee session. It was a great pleasure to have you here. From here, I'll then hand over to Shreyas Gajar, who would be chairing the shoulder session. Shreyas, over to you, please.
Okay. Thank you, Pranjal. And yes, Dr. Narvekar, you have something to say? You're on mute, Dr. Narvekar.
Yeah, thank you. This is just to thank our session is over.
Okay. No, thank you everyone for the excellent knee talks, and thank you, Pranjal. So we move on to the shoulder session. Again, we've got eminent faculties in this session, and the first talk is by Dr. Nicholas Antau on AC joint dislocations. Do we still screw it up?
I thank the BOS for giving me this opportunity to talk in this master series on acromioclavicular joint injuries. The AC joint is a diarthroidal synovial joint between the lateral end of the clavicle and acromion of the scapula, interposed with a disc of fibrocartilage. And this disc is of three types: type 1, ellipsoid in 4% cases, type 2, A and B, incomplete 25% cases, and absent in 75% cases. The clavicle rotates 40 to 50 degrees on its long axis in synchrony with the scapular motion when you elevate the arm, and only 5 to 8 degrees of motion occur at the AC joint in terms of elevation, depression, protraction, retraction. Inclination of the AC joint varies from 10 degrees to 50 degrees, and the disc starts degenerating after 40 years. The AC joint is stabilized by the AC ligaments and CC ligaments. The AC joint capsule has both superior, inferior, anterior, and posterior components. The superior component being the strongest, 56%, posterior component, 25%, and they both act as restraint for horizontal displacement and for axial rotation. The AC ligaments run from the coracoid process to the acromion, and depending upon its configuration, there are the broad type when the width is the same, quadrangular type when the width at the coracoid is more than the acromion, and attachment Y-shaped at the coracoid and multiband shaped. The coracoclavicular ligaments are two, conoid and trapezoid. Conoid is cone-shaped, located 47.8 mm in males and 42.8 mm in females from the lateral end of the clavicle. Trapezoid is oval-shaped, located at 25.4 mm in males and 22.9 mm in females from the lateral end of the clavicle. And this is very important when you exercise the lateral end of the clavicle. The mean length is about 19 mm. The conoid are important for vertical and horizontal stability of the clavicle. The trapezoid is important for axial compression restraint. There are variations in the CC ligaments. And this variation, the common type is 52%, confluent type where it has extension going over the superior transverse scapular ligament, type 2 in 33% of the cases, and accessory lateral fascicle type 3 in 15% of the cases. This morphological arrangement may also predispose the patient to suprascapular nerve entrapment, which has been suggested as the cause of nerve compression. The coracoid, normally thought to be curved, can also be flat. Knowledge is important when you pass a loop to avoid it from slipping. The overall mean width of the coracoid varies from 9.2 to 23.3 mm, whereas the clavicle width varies from 11.1 to 25.3 mm. Dynamic stability of the AC joint is through the muscles, deltoid and trapezius. And in deltoid paralysis, that's why the lateral end of the clavicle is prominent. Blood supply comes from the subclavian artery through its branches, suprascapular artery, and also from the axillary artery, where the branches come through the thoracoacromial arteries. AC joint is innervated by articular branches of the suprascapular, axillary, and lateral pectoral nerves arising from the brachial plexus. Pain arising from the AC joint may be referred to the neck, trapezius, lateral, deltoid, and shoulder. AC joint injuries result as a fall on the outstretched hand with an impact on the shoulder, and always have an abrasion in that shoulder or on a flexed elbow, and they make up for 12% of all shoulder dislocation, males being more affected than females in the ratio 5:1. Many clinical signs are there, but the most prominent signs are the prominence of the lateral end of the clavicle, piano key sign, more specific sign is again a Bryan active compression test. When you lift up the ham against resistance, or most sensitive again is the cross body adduction stress test described by Chronopaulus. What happens in AC joint injuries? There is a superior or posterior superior migration of the distal clavicle, and this results in orientation of the scapula and the rotator cuff because of the depression of the scapula, anterior tilting of the scapula, and internal rotation of the scapula by the pull of the muscles, pectoralis minor, rhomboids, and levator scapulae. This results in chronic painful scapular dyskinesias or sick scapular syndrome. X-rays are taken normally with a traction weight in the hand or the Zanka view with the tube inclined at 30 degrees, 20 to 30 degrees. Most common view is the Alexander Obasamane view, taken in elevation and adduction, and axillary view. And what we see here is a coracoclavicular distance called CC distance, which is normally up to about 12 to 14 millimeters. But when it is anything more than 14 mm, it is pathological. And one must be beware. You can have dislocation of the AC joint with normal CC distance when there is a fracture of the tip of the coracoid, middle of the coracoid, or that matter, base of the coracoid, or there is a fracture of the distal end of the clavicle or facial injury of the clavicle. And therefore, CT scan is important to note these fractures of the coracoid, or that matter, fractures of the glenoid, anterior or posterior margin. And nowadays, a lot of researchers have done MRI and they have found associated lesions in the slap and rotator cuff to the extent of 30 to 50%. And then that's why they advise taking MRI and CT scan for all acromia clavicular joint injuries when you suspect. Classification that is used for this is the Rockwood classification. Type 1 AC ligament strain with CC normal. Type 2 AC ligament is torn and CC sprain. Type 3 AC and CC ligaments are torn and the clavicle is elevated above the border of this acromion. And there is an increase in 25 to 100% in the CC distance. The Issacost study group has classified these three into A and B. In A, there is a vertical instability, no horizontal instability, and the reduction is possible, whereas in type B, it is difficult to reduce the AC joint because of the horizontal instability. Type 4, there is AC, CC joints, both are torn, and again, there is a displacement high up into the trapezius muscle, sometimes rupture of the trapezius muscle or deltoid, and there's a skin tenting with posterior fullness, and this reduction is not possible. This dislocation is not possible to reduce. Type 4, severe injury, where the displacement is much more than 100% than the contralateral CC distance, with severe shoulder droop, which does not improve with shrugging. And type 6 is with the AC and CC ligament torn, the clavicle is just under the acromion or sometimes even at the under the coracoid, with patients having severe paresthesias. Some people nowadays talk about type 7, where there's a fracture of the lateral end of the clavicle within 5 millimeters, or that matter, fracture of the acromion within 5 millimeters of the joint, with the fracture tip of the coracoid or the middle of the coracoid or the base of the coracoid with CC distance remaining the same. Bipolar dislocation with dislocation at the sternoclavicular and AC joint was also taken as type 8. also called the floating clavicle. Algorithm for management. Type 1, type 2. Primarily conservative management is the type 3, which is controversial, and the psychos groups this divides into 3A and 3B. 3A, where the reduction is possible of the dislocation, they could be treated conservatively, but if the pain persists and the rehab is not successful, they are operated. 3B, again, even high demand athletes and manual laborers and high demand personalities, they do primary operative treatment together with type 4 and type 6. And if that is the rehab is not successful and still painful, then they advocate secondary operative treatment. Hence, the goals of management are appropriate timely treatment as per the type of dislocation, age, occupation, and sports, which helps to permit to return to work, sports, and life as quickly and as safely as possible, restoring pre-injury level of performance. Conservative treatment showing taping, bracing, and strapping. There can be complications of conservative treatment. Despite good treatment, persistent pain can remain, osteolysis of the clavicle can result, post-traumatic arthritis can result, and recurrent AP subluxation can result because of the trapped ligament pieces or cartilage pieces. This is a case of 35-year-old follow-up of a conservative case, conservatively treated case of my nephew, who is a national goalkeeper. He is now 57, and he did not want the operation, and that is the function. Indication for surgery, besides what is mentioned in the algorithm, extra presence of scapulothoracic dysfunction, failure of conservative treatment, risk of re-injury, and type 7 and type 8 needs to be included. And what are the principles of fixation? Either one can do surgery of the AC joint by excision or reconstruction. The second part is reconstruction of the CC ligaments alone, or CC and AC ligaments together, called the combined therapy, or and in chronic AC joint arthrosis, decompression. The different modes of fixation of CC by K-wire, hook plate, Westwood screw, circlage wire, Devar, Barrington, which are given up nowadays because of many complications of K-wire breakage, slippage, migration, plate causing erosion, malposition of the screw, irritation, and second surgery for removal. First paper on of Devar Barrington procedure published in IGO in 1994 had complications like non-union, fracture of the coracoid tip, also fracture of the screw and subluxation. So that's given up. Ander Leenhops did biomedical study and showed that corkscrew fiber by number 5 and native ligament strain corkscrew number 5 is much more compared to corkscrew FT and 3.5, whereas bicortical boss corkscrew is somewhere near 726 newtons, and the muslin tape and corkscrew 3.5 come to near 500. This repair can be done either single tightrope, double tightrope in the U configuration or Y, V configuration, or using 2 suture anchors, or the hamstring tendon graft, which was first pioneered by Laurent Lafosse. This is a video of this ligament reconstruction using this tape. Drill, the tape is brought out to the hole and tied over a button and fixed, giving good stability. Various combined CC and AC joint repair methods are available as shown in this diagram. Banja and Chen and Artha. Published a study on arthroscopy assisted AC joint and anatomical AC joint reconstruction. They felt there was a better outcome with this when they did AC joint fixation alone. But the complication rates and failure rates were significant challenge in terms of breakage of the clavicle, migration of the endobutton, or even skin irritation of the K-wire and infection. Nazar Salem tried to reconstruct the two bundles of the CC ligaments, the conoid and the trapezoid, like the two bundles of the ACL, using the part of the short head of biceps and coracobrachialis, and found good results. Complication rate of arthroscopy is 3.8%, open surgery method is 5%, open tendon grafting is 8%. And this is a study by Heppenstall published in AJSM with different types of fixation, overall complication rate being 42.1% and reoperation rate with 7.3%. Why complication? According to Cole, Dynes and Bedi group, transclavicular coracoid reconstruction techniques cannot restore the footprints of the conoid and trapezoid ligament without significant risk of cortical breach and fracture. Attempts to correct this non-anatomical configuration by creating a tunnel based on the anatomical footprints results in nearly universal medial cortical breach of the coracoid process in 90% of the cases. That was their conclusion. Comparative studies of operative versus non-operative by Antti Jokanen from Finland and Tang from China. They felt that the non-operative treatment was shown to produce more prominent or unstable and radiologically wider AC joint than operative, but clinical results were good in 18 to 20 years follow-up. Both treatment methods showed significant radiographic elevations of the clavicle. This is an example of combined AC and CC joint reconstruction. Another nephew of mine who had a traumatic dislocation grade 4, which was operated by using two muslin tapes as in this configuration, and the repair of the AC ligament was done with a fiber tape suture. Example, after rehabilitation, that's the function. Current concept in management of the AC joint dislocation, systematic analysis, operative techniques by Goud and Verma show that overall failure rates is 20.8%, fracture coracoid and clavicle 5.7%, hardware rate 4.2%. Open drilling and clavicle had more fracture than arthroscopy. Joan Waters reported in Arthroscopy 21 that using hybrid synthetic graft wrapped without drilling tunnels had CC distance more than 4 mm compared to the normal shoulder, good function, but loss of reduction, both CC and AC joint reconstruction 11.5% and CC alone 38.7%. This is a case 7 operated, type 7 operated fracture tip of the coracoid with suture anchor, all suture, and repair of the AC ligament with excellent results. In chronic AC joint arthrosis, conservative treatment or sometimes we give injection or surgical or open treatment of the decompression of the AC joint also gives good results. The classical Weaver Dunn procedure is nowadays modified by Boileau group, where they take us 5 mm of the acromion and with the AC ligament, and the clavicle is widened with a burr, and this is impacted into this, and drill holes are passed, and this thread is pulled out and tied over a endo button. At the same time, they do repair of the CC ligaments with good results. My approach, conservative treatment for cases up to grade 3A and B, depending upon the profession. If the pain is persisting despite the conservative treatment, then I advise surgery for high demand patients. Shoulder arthroscopy, I first do if the MRI shows soft tissue involvement like slap and rotator cuff injuries, and I do a mini open procedure for CC fixation, keeping the remnants of the ligaments using 2 muslin tapes hooked or looped around the coracoid in the direction of the CC ligament. Suturing of the AC ligament is done with drills through the suture, reinforced with tiger tapes, as you can see in this scenario. Thank you very much for your kind attention.
Thank you, Dr. Antau, for that excellent overview on this emerging topic. The next talk is on the unstable shoulder much beyond Bankart repair by Dr. Sanjay Desai.
I would like to thank Bombay Orthopedic Society and the organizers of the MasterShare series. And thank you very much for giving me this opportunity to share my experience on the unstable shoulder. A large part of my talk will be on the more common recurrent anterior dislocation of shoulder, and then a few thoughts on posterior instability and multidirectional instability. Anterior shoulder instability problem has been existing for thousands of years, first described by Papyrus 3,000 years before Christ. The salient landmark time was Bankart repair, described by Bankart in 1939, the capsule labrum repair. Letarge 1954. Helfet from England popularized the technique and gave it the name of his mentor, calling it the Bristow procedure. And then finally, Norisat in 1987 described the arthroscopic assisted mini open in cadaver, and eventually Laura Lafosse and Pascal Beaulieu described the arthroscopic Letarge in 2007. Now, when you deal with recurrent anterior dislocation of shoulder, there are many factors to consider. But the main ones, besides age and activity, is the quality of soft tissue and the extent of bone loss. Soft tissue assessment is crucial, especially in our country. And we must assess generalized ligament laxity, which is usually done by clinical examination, and certain shoulder-specific laxity, which is often done by arthroscopy. We all are aware of the Brighton 9 criteria, but it's very hard to execute this in a busy clinic, examining all the 9 criteria. So what we do is we utilize this one criteria of passively bringing the thumb to touch the volar aspect of forearm. If the thumb comes to parallel of the forearm, that's grade 1. Beyond parallel but cannot touch the volar side of forearm, grade 2. And grade 3 is easily able to touch the forearm. This we use as a criteria, and it has been validated by Cahill, April 2020. What we found was more than 30% of patients with recurrent anterior dislocation will have some amount of laxity, which is grade 2 or 3. And there is a significant correlation between this significant lax people and the recurrence rate following arthroscopic soft tissue procedure. How do you assess the quality of capsule? Or we have attempted to quantify the capsule. Look at this, 4 different patients with unstable shoulder, and that is the anterior band of inferior glenohumeral ligament. If you notice that they are so different, they cannot be ignored. I strongly believe that they have to have some significance. So we did some statistical analysis, and this is the end result, that if you have the anterior band, which is less than 4 millimeters or absent, which is capsule type 3 and 4, that is significant. You may want to label it as a pathological capsule. And if you notice here, there are 50 patients with unstable shoulder who underwent arthroscopy, and a control group of patients who underwent arthroscopy of the shoulder for other reasons like rotator cuff repair. And if you look at the pathological capsule, which means 4 millimeter or less, it is much more incidence in the unstable group as compared to the control group. If you look at the bar, 20% versus 60%, so highly significant. And if you look at this graph, as the extent of ligament laxity increases, the quality of capsule also deteriorates. So your assessment of generalized ligament laxity will give you some hint of the quality of capsule that you will see inside the shoulder joint. How do we assess bone loss? My preferred method is using a CT scan, though arthroscopy can also be used. My preferred technique of measuring the bone loss is by the best fit circle method of Sugaya, where the bone loss or the fragment is represented as a percentage of the circle which is formed on the lower quadrant of the glenoid. Occasionally, we have patients who come with a CT scan and the radiologist has not measured the bone loss. So this is what we use. We overlap a template with concentric circles, identify the center of the glenoid, measure the angle alpha, and if the angle alpha is 120 degrees, then it is equivalent to 20% glenoid bone loss. How do we assess the Hill sacks? All of us are familiar with the glenoid tract concept. In simple words, if the Hill sacks lesion is so large that the area is more than the glenoid contact area, then it would be considered as off track, what we always used to call an engaging Hill sacks. So this is the most important slide of my presentation. My approach when I see a patient of recurrent anterior dislocation. Remember that in our population, 30% or more have poor quality of soft tissue. So now let's analyze this slide. If you have glenoid bone loss of less than 20%, I would do an arthroscopic Bankart repair. And this I see in almost 90% of our cases. Whereas if you have a glenoid bone loss, which is significant, more than 20%, or in a subset, if it is an off track, which is seen in total of about 10%, I would go ahead and do a Letarge as a primary procedure. Now, even if the bone loss is not significant, which is less than 20%, but the quality of capsule is poor, I would still consider Letarge if the patient is high demand, which means sportsmen who are involved in contact sports such as kabaddi or wrestling. Whereas patient with less than 20% glenoid bone loss has a poor soft tissue but is a low demand. Say he is a manager in a bank. Then after counseling the patient, I would go ahead and do an arthroscopic Bankart repair. So if this 30% population, if you were sitting in Europe, then 10% significant bone loss, 30% poor soft tissue, and therefore 40% would undergo Letarge. Whereas as against that, in a country like India, out of that 30 with poor soft tissue, hardly a small percentage will have contact sports involvement. And hence the disparity between the percentage of Letarge in India versus the rest of the world, like the European nation or United States. I have no dispute. If I have a patient with glenoid bone loss, which is, as you see here in the slide, 40% or 50%, of course I would do a lethargia procedure. The technique, we all are now very familiar. The coracoid undersurface is sitting on the glenoid, flush to the glenoid articular surface and fixed with 2 screws. How does it work? I think it works because of retention of the lower half of the subscap, added with the sling effect of the conjoint tendon. I'm not so sure how much of the bone functions as a bone block itself. 2 techniques which are popular at the moment, the classic technique, which is my preferred technique, and the congruent arc. In the classic technique, the inferior surface of the coracoid sits on the neck of the glenoid, flush to the articular surface. Whereas in the congruent arc, the inferior surface is turned and it's in continuity with the glenoid articular surface because the curvature matches. I prefer the classic technique because it worked well in my hands. I am more interested in ensuring that this bone piece heals well and it gives a broader surface area. It is relatively easier to pass 2 screws because of the broad surface area, and hence it is my preferred technique. And if you look at the literature, I don't think there is any significant difference in the results between the 2 techniques. Lethargia works and is a useful procedure. I have no doubt in that. However, I want to draw your attention that when you do a lethargia procedure, in the absence of significant bone loss, you must remember that it is a non-physiological procedure, almost like a salvage procedure. It can have problems. It is a high complication rate surgery. Non-union 20%, osteolysis, this is Bolio himself. Then graft osteolysis identified and recorded by Giacomo, almost 60%. Coracoid malpositioning is a common problem. Osteoarthritis in almost a quarter of the lethargia procedures by Jill Walsh in the long-term 25-year-old follow-up. Hovelius published a high incidence of osteoarthritis in the long run. Overall complications of lethargia can be almost 30%. Now my take on remplissage. To me, the concept is not convincing. Why? In 2000, Joe DeBeer and Steve Burkhardt taught us that if there is significant glenoid bone loss, do not do soft tissue procedure, it will fail. On the same basis, now we are being told that if you have a bone loss on the humeral side, please do a soft tissue procedure. That is probably a concept which is very difficult to accept. Let's look at the world opinion. So here is the systematic review, a very large systematic review, very recent, February 2021. Arthroscopic Bankart repair plus remplissage has a high failure rate when the glenoid bone loss is more than 10%. And what is their recommendation in the systematic review? That do a remplissage if you have a glenoid bone loss less than 10%, but with a large Hill-Sachs lesion. Now my question to you, gentlemen, is how often do you see a very large Hill-Sachs lesion? We are looking at 30% more without significant glenoid bone loss, which is less than 10%. Very unusual. So to me, remplissage works very well when you don't need it. This published table of guiding when to do lethargia and remplissage. Look at number 4. If you have a glenoid defect which is significant and an off track, you do a lethargia plus remplissage. When will I do a lethargia plus remplissage? Never. Here is an example of a patient who came literally in tears, wanting to disarticulate the arm. Somebody had done by the book lethargia plus remplissage, and he was in so much pain. The key is arthroscopic Bankart repair remains the main treatment option, but it has to be done meticulously, understanding how to do it and what is our aim. And in this few slides, I'm going to show you what I do and why I do. You need a lot of equipment. You need certain special instruments, lateral position, tilted posteriorly. Organizing your OR is crucial for every step to go well. 3 portals. The pencil is pointing towards the anterior superior portal where I will switch my scope after entering from the posterior portal. The whole operation should be done looking from the anterior superior portal because you can see the glenoid neck much better And unless you see it well, you'll not be able to do a good Bankart repair. You must be aware of the 3 nerves and how to enter from safe areas in the shoulder joint. Remember, what is the aim? It is to reconstruct the pathologic anatomy. And also remind yourself all the time that these are not anterior dislocations, these are antero-inferior dislocations. So what is the aim of Bankart repair? One is to retension the antero-inferior capsule and get the capsule to heal to the glenoid. That's the key. You must realize that it's not easy to achieve that. Healing of soft tissue to bone, whether it is rotator cuff, whether it's ACL or a patella tendon, has been a challenge for years. And therefore, do not presume that it will heal easily unless you take extra care. And extra care means mobilize the capsule well. I spend half the surgical time in mobilizing the capsule and preparing the neck. And also remember, it's important to create an interface on the glenoid edge by curating it and exposing fresh bleeding surface. You need that interface for that capsule to heal into the glenoid face, and use minimum 3 anchors, sometimes 4. Curating the glenoid has been well established now. I have published this in 2021 in the Arthroscopy journal that makes a difference in the recurrence rate, perhaps because of better healing. So here is the surgical technique. I am going to run it a little fast so that we can save time. Switch the scope into the antero-superior portal. There you go. And then mobilize the capsule well all around up to the 6 o'clock position. Measure the anterior band. So this is more than 4 millimeters, and therefore it is probably a healthy quality of capsule. Mobilization is crucial. Rasp the neck, as you always do, but over and above rasping the neck, it is extremely important to curate the edge of the articular surface, because capsule is unlikely to heal to the relatively avascular glenoid articular cartilage, and put your anchors in that curated gutter, which will be filled by the capsule labrum complex. And once you do that, I will then show you the final result and how the capsule labrum soft tissue is rolled up and fitted kind of into the curated glenoid, and hoping that this is the best possible interface for this soft tissue to heal into bone. What is the problem with current technique of stabilization? It's healing. I think that's the real key. We do not have any study which proves that our arthroscopic Bankart repair actually healed. Besides, very often I think there is inadequate and improper tightening of the inferior capsule. Of course, the capsule could be inherently poor, but that is a genetic problem hard to solve at this stage. A few slides on posterior instability. Salient features. Number one, it's uncommon. Pain is the most common presentation, not recurrent dislocation. They are often subluxations rather than dislocations, and it is very often an overuse problem. Certain peculiarities of posterior instability. The reverse Bankart is minimally displaced. You might even miss it, and I'll show you a video. Reverse Hill-Sachs is often indistinct, and pure trauma rarely leads to recurrent instability. It is microtrauma which is the main cause of posterior instability. So here is the posterior Bankart lesion. Unless you probe it and really look for it, you might just miss this lesion. See, you can't make out that there is a Bankart lesion. And if you compare it to a normal anterior labrum, which I will show you in a minute, and there you go, how the labrum is sitting nicely on top anteriorly. What is the mechanics? You have repeated trauma or micro injury leading to capsular laxity, and you end up with rim loading posterior labrum lesions, eventually ending up with pain and instability. And here is rim loading. There are certain tests which are important to pick up. It's a high index of suspicion which gives you the diagnosis of posterior instability. The jerk test I prefer to do in a supine position. Imaging is crucial because you want to pick up those rare, uncommon, severe varieties of posterior instability. Here is a reverse Bankart lesion. Here is bottom right, a very severe variety of glenoid hypoplasia leading to posterior instability. Here is a medical professional, a doctor with a very severe variety of glenoid hypoplasia leading to posterior instability. Example of a reverse ALPSA, posterior ligamento-periosteal sleeve avulsion. Here is an example of a reverse Hagel. So unless you are aware and you look for these, you might miss them. And of course, we all know the Bennett lesion. So posterior instability, the common surgeries which I would consider are a posterior Bankart repair or a posterior capsulorrhaphy. Just a few tips: when you do a posterior Bankart surgery, remember that the posterior portal needs to be modified so that your angle of the drill is such that it doesn't skive off. That's the Kim's portal, and you need to pre-plan before you make the portals. There are many open surgeries described. I have very little experience, but for those who deal with posterior instability often may want to look at these. Be careful when you counsel the patient. The satisfaction rate with posterior instability surgery is somewhere between 70 to 80%. In summary, posterior instability is uncommon. It is more due to overuse. Subluxation is the presentation, not dislocation, and it is much more than just a reverse Bankart lesion. Multidirectional instability of the shoulder. It is symptomatic anterior plus posterior with a positive sulcus. Etiopathogenesis is mainly a muscle coordination problem. It's an imbalance, poor proprioception, and they often have scapular dyskinesia. Majority of these can be managed without surgery, and that would consist of stabilizing the scapula, rehabilitating the rotator cuff, and you must ask the physio to see if they can correct the abnormal muscle firing, and biofeedback seems to help in achieving this. Warning, when you have multidirectional, they can be voluntary or connective tissue disorders. They are contraindications for any surgical procedure. In my experience, I feel that MDI are basically patients born with very severe generalized ligament laxity, and they develop painful instability only in one direction. So you're born with GLL, you may develop an anterior-inferior painful instability or a posterior-inferior. Remember, inferior component is common to both. In summary, MDI is uncommon. It usually does not need surgery. It is often a constitutional problem. So ladies and gentlemen, when you deal with an unstable shoulder, beware, a lot of things can go wrong. And lastly, I thank Bombay Orthopedic Society for the opportunity. Thank you.
Thank you, Dr. Desai, for that excellent evidence and experience-based talk. The final talk is on massive rotator cuff repairs, recent advances in preservation techniques by Dr. Deepak Bhatia.
Thank you, Bombay Orthopedic Society, for this opportunity. I will be speaking on joint preservation strategies in massive and irreparable rotator cuff tears. A massive irreparable cuff tear is one that cannot be repaired surgically due to either poor tissue quality or loss of tissue mobility. There are several independent predictors of irreparability that help us understand and define these tears better. The most important ones are the presence of severe retraction, severe atrophy, and humeral head ascension. And when we see a combination of these three, the likelihood of irreparability of the tear is 93%. Now, surgical repair of these tears is difficult because of reduced mobility in the tendons, adherence of the tendons to the subacromial structures, and presence of delamination in these tears. There is added difficulty if you're dealing with a previously failed repair, if there are large loose anchors in situ, or if there is osteopenia and osteoporosis. The repairs are more likely to fail in these tears. Repair failures could be due to biological factors such as poor tendon quality, hypovascularity, or poor bridging at the bone-tendon junction. Repair failures could also be due to structural factors like incomplete repair in multiple tendon tears, inadequate releases in a chronically retracted tear, using inadequate anchors that results in a suboptimal repair configuration, and using anchors with an inferior pull-out strength. The reverse shoulder prosthesis is not an option in these tests because the joint is non-arthritic and the age group is generally lower than the cuff tear arthropathy group. Also, the reverse shoulder prosthesis has shown a high failure rate at 5 years, and there is a high incidence of complications. Recent advances in arthroscopic techniques have provided several joint preserving solutions. These tears can now be repaired partially or completely using modern arthroscopic techniques. The repairs can be further augmented using cells, bioactive scaffolds, or biological autografts. The ones that cannot be repaired can be reconstructed using a superior capsular reconstruction procedure or tendon transfers. And lastly, the joint can be salvaged using subacromial spacers. Arthroscopic repair is possible in over 90% of the irreparable tears. The repairs may be either partial or complete. Outcomes correlate directly with the surgeon's expertise, and in general, a complete repair has better outcomes than a partial repair. While performing an arthroscopic repair, it is necessary to repair the subscapularis if it is torn. The tendons should be released adequately from the bursal aspect and from the articular side of the joint. The tear pattern should be identified correctly, and apical margin convergence should be used when dealing with tissue deficiencies. An optimal number of anchors is necessary to provide a good repair construct. In general, for a triple tendon tear with a biceps tenodesis, a minimum of 5 double-loaded anchors is necessary. And lastly, a tension-free repair should be achieved with the arm and adduction, and the tendon-bone junction should be repaired watertight. For weak and degenerative tissues, the repairs should be performed with an augmentation. Cuff repair augmentation could be either cell-based using a variety of cells, or it could be biostructural using bioinductive membranes, autografts, or the subacromial bursa. The cell-based strategies utilize the platelet-rich plasma, bone marrow aspirate from the humeral head, and subacromial bursa. The tissues are mixed together to form a clot, and the clot is then directly applied over the tendon surface after the repair. Alternately, a device known as the graft net may be attached to the end of the shaver, and the subacromial bursa is debrided. After debridement, the bursal shavings can be retrieved from this device and can be re-injected back into the shoulder to be applied onto the surface of the repaired tendons. Biostructural augmentation is performed using bioinductive membranes, but these membranes cost thousands of dollars, so the routine use is currently not possible in our scenario. Biostructural augmentation can also be performed using autografts such as the intact subacromial bursa and the long head of the biceps. Now, the subacromial bursa is a tissue that's readily available. It is an autograft, it is easily harvestable and vascular, and it has shown to have sufficient mechanical strength. Current evidence shows that the bursa contains multipotent cells which are capable of multilineage differentiation, and therefore the subacromial bursa forms an excellent graft for both structural and biological augmentation. The subacromial bursa extends from medial to lateral. It is thicker medially and posteriorly and much thinner laterally. It is vascular, and this vascularity can be preserved, and the bursa can be dissected and mobilized as an entire layer. There are two techniques in which the bursa can be used. The first one involves using the lateral bursal layer and stitching it to the bone tendon junction over the repair. And the second technique involves harvesting the entire bursa with its vascular attachments preserved. So this is a vascular duvet technique of bursal augmentation. The bursa is dissected from medial to lateral, and the medial and lateral attachments are left intact. The vascularity on the deeper aspect of the bursa is preserved, and this area is not dissected. The bursa is adequately mobilized so that it can be pulled anteriorly and laterally to cover the tendons after the repair. Once the anchors are inserted, sutures are passed through the tendon and the bursa separately, and when the knots are tied, the bursa is seen to move anteriorly and laterally and covers the tendons and the repair site. Post-operative imaging has shown integration of the bursa with the cuff tendons, and in general, these tendons are much thicker than the non-augmented ones. The biceps autograft, again, is a tissue that's readily available and easily harvestable. It has sufficient mechanical strength and can be converted to a scaffold. Current evidence shows that the biceps tendon contains viable tenocytes, and incorporating the biceps in the repair results in a lower retear rate and an increased acromiohumeral distance. So this is the biceps bursa composite repair technique. The first step is to do a biceps stenodesis within the groove using suture anchors. Once the biceps is stenodesed, it is cut proximal to the tenodesis site, and this gives us a graft size of about 2 to 3 centimeters in length. The next step is to release the tendons adequately in the subacromial space, and the bursa is dissected with its vascular attachments preserved. Next, a minimum of 3 to 4 double-loaded anchors are inserted into the tuberosity, and sutures are passed through the biceps tendon and then through the cuff and the bursa, either separately or together. Finally, when the knots are tied, the bursa is seen to augment the bursal aspect of the repair, and the long end of the biceps can be seen from the intra-articular aspect. Post-operative imaging again shows good integration of the biceps and the bursa with the tendons, and these tendons again are much thicker than the non-augmented ones. Now, these are some of the outcomes of the augmented repairs. This is a 2-year follow-up of a 75-year-old doctor with a massive irreparable rotator cuff tear. And this is his post-operative sonography that shows intact and thick tendons at 2 years. This is a 2-year follow-up of an 85-year-old patient with a massive tear who was treated with an augmented repair. Now, if for some reason the tendons cannot be reconstructed, then they cannot be repaired, then they can be reconstructed using a superior capsular reconstruction or a tendon transfer. Superior capsular reconstruction involves attaching a tissue to the glenoid and the humeral side. The tissue used is generally the fascia lata or a commercially available dermal matrix, or even the biceps tendon. The tissue is folded over to create a graft that is at least 8 millimeters in thickness and is then sutured to the glenoid and the humeral aspect. Superior capsular reconstructions have shown good outcomes clinically. However, graft failures are high on MRI, the reoperation rate is high, and the overall complication rate ranges from 5 to 70%. Tendon transfers can be used to recreate the vectors of the irreparable tendons, and the tendons generally used are the pectoralis major, the lat dorsi or the teres major, the lower trapezius, and the middle trapezius. Generally, for an anterior superior deficiency, the pectoralis major tendon is preferred. For a posterior superior deficiency, the lat dorsi or the lower trapezius is used, and for combined deficiencies, a combination of these tendons can be used. The pectoralis major tendon is used for an irreparable subscapularis tear, and the prerequisite is that the associated supraspinatus tear should be repairable. The upper 2/3 of the pectoralis major is harvested and is rerouted under the conjoint tendon to recreate the subscapularis vector. The tendon is then attached to the lesser tuberosity and provides good functional outcomes. The lat dorsi tendon is used for irreparable posterior superior tears. The prerequisite is that the subscapularis should be intact and the teres minor should be hypertrophic. The lower trapezius transfer is a new tendon transfer. The only disadvantage here is that the tendon length is inadequate and a bridging allograft is necessary to attach it to the humeral aspect. Middle trapezius transfer is a new transfer that is currently under evaluation. It involves dissecting the middle trapezius from the acromion, and the tendon is then rerouted under the acromion to attach it to the tuberosity. For combined deficiencies, I generally use the pectoralis major, the teres major, and the latissimus dorsi tendons. The pec major tendon again is rerouted under the conjoint tendon and attached to the tuberosity, and the lat dorsi and the teres major are rerouted posterior to the humeral head and attached onto the anterior aspect to provide external rotation. Lastly, the balloon spacer is a salvage option in irreparable tears. The synthetic balloon can be inserted and insufflated in the subacromial space and provide superior stability to the joint. However, the outcomes are unpredictable and there are problems with spacer degradation, so this is not recommended for routine use currently. So in summary, massive tears without arthritis, joint preservation is mandatory. More than 90% of the irreparable tears can be repaired arthroscopically. Bio-augmented repair is a good option for weak and degenerative tissues. Subacromial bursa and biceps are biologically active grafts and should be used for biological augmentation. The superior capsular reconstruction has shown good outcomes. However, the complication rates are high and tendon transfers and spacers have unpredictable outcomes. Thank you.
Thank you, Deepak, for that brief overview on this complex problem of massive rotator cuff tears. I would now like to ask Dr. Nagaraj Shetty, my co-moderator for the case discussion session, to kindly share the screen. And I would request all the panelists from the shoulder session, Dr. Desai, Dr. Antau, Dr. Deepak Bhatia, and also from the knee session, Dr. Narvekar, Dr. Joshi, Pranjal, and Dr. Vijay Shetty to participate. Nagaraj, in the interest of time, I would just request you to proceed briefly and be direct, and please address the faculty directly with your questions. Thank you. Over to you.
Thank you, Shreyas, Dr. Pranjal and Bombay Orthopedic Society for this opportunity. It's a very nice case to follow up with the good presentation of Deepak, because I'm presenting a massive, deemed irreparable rotator cuff tear with true pseudoparalysis. This is my profile in brief. I had a patient who was a 63-year-old lady. She came with acute and chronic pain in her non-dominant left shoulder in Feb of 2020. She had a very trivial injury to her left shoulder in the form of a sudden jerk while climbing down stairs in December 2020. She was doing well with some conservative treatment initially, but her pain kept on worsening and her weakness kept on worsening. So it's not a single major traumatic event. It's not an acute event. It's an acute and chronic kind of a situation. She did have on and off pain in that affected shoulder in the past too. This is her clinical examination picture. So she has true pseudoparalysis, meaning she can't initiate even the early forward elevation. She has an external rotation lag sign, so she cannot hold her arm in external rotation. It drops back to neutral. She's very painful. Her teres minor function has been evaluated now, and you can see in abduction and her belly press was normal. So her subscapularis was normal. These are her MRI findings. So she came with a massive retracted 2-tendon tear. So this falls into the category of a irreparable tear in terms of the degree of retraction. Now let's see in terms of the number of tendons, more than 2 tendons or 2 tendons in this case. In terms of the retraction, it's gone almost up to the level of the glenoid. The infraspinatus is also significantly retracted. We then need to see the Y image where we see the Goutallier staging and the tangent sign. So when we draw the tangent, we realize that there is significant loss of muscle volume. There is about a grade 2 fatty infiltration. However, the infraspinatus looks quite bad in terms of almost grade 2 to grade 3 fatty infiltration. There is no teres minor hypertrophy. With this, the obvious question is, what are the treatment options? Whether we offer a palliative surgery for pain relief like debridement and tuberoplasty, whether we attempt a partial repair with the hope of restoring the force couple, and the concept being described by Stephen Buchhardt is to at least repair the anterior infraspinatus and the superior subscapularis. And once the force couples are in place, the patient can have some function. Can we think of complete repair? Can we think about the various options which Deepak talked about, like using the bursa or the biceps, like an augment in your partial repair? Or shall we give her tendon transfers? Or shall we go for a reverse shoulder replacement, which, as we know, is the only surgery as of today that ensures 90% efficiency of reversal of pseudoparalysis? So with these questions in mind, I'd like to ask my elite faculty, what would be their treatment options? And let's try to keep it brief so we can discuss more and more. So Deepak, can I ask you, what would be your treatment option for this lady with pseudoparalysis? She's 63 years of age.
So, given her age and the fact that she has a 2-tendon tear with only about grade 2 to 3, say grade 2 in the supraspinatus and about 2 to 3 in the infraspinatus, I think this is still a tear where repair should be attempted. And if needed, there are augmentation methods, like I said, the subacromial bursa or the biceps. So I don't think the biceps will be needed here because the supraspinatus looks good enough. But for the infra, I think the subacromial bursa augmentation would work over here. So I think that would be what I would attempt.
Great. So Deepak pointed out very good points in terms of assessing. He tried to assess the tendon quality, the tear pattern on the MRI images. He also talked about the fatty infiltration. Desai sir, anything else to add? With your experience, what would you suggest?
All I would highlight is that do not depend on the MRI for repairability. Go on the clinical history. The symptoms worsened 6 months ago. So chances of this cuff being repairable are high. If not completely, then fairly good repair, even if it is partial, enough to have a reasonable result. However, when I undertake this arthroscopic procedure in such patients, I will counsel and consent and keep the reverse standby.
Great. So there's a good perspective that's come out, and that is what I was also thinking in these lines. So we have a non-arthritic shoulder in a relatively young patient who's low demand. The tear pattern is probably a reverse L. There is grade 2 fatty infiltration in the supra, grade 2 to 3 in the infra. Her teres minor is intact, which is a good sign, and there's no hypertrophy, which tells me that probably this is not as chronic. However, as Dr. Desai mentioned, intraoperative arthroscopy understanding could be totally different from what we see on MRI. Another important sign which we need to stress upon is that she had a maintained acromial-humeral distance. Another good sign that tells us that she's relatively compensated, although she is true pseudoparalytic. So I planned for trying my best in terms of an arthroscopic repair. Unlike Dr. Desai, and Dr. Desai also would agree that it's a huge task to convert an arthroscopic surgery to a reverse shoulder. I rather decided on relying on my arthroscopic repair techniques and probably using an SCR as a backup, and that is what she was counseled. And it was very important to lower her expectation in terms of the final outcome. With this in mind, this was her tear pattern. This is a combination of cases in the same category. So it's about 2 cases which actually I will show. So very poor reducibility. You need to identify the tear pattern. This is the identification for the subacromial space. So this looks like a reverse L shape of tear. That's the supra, and then the posterior portion is the infra. You can see there is tendon loss too. The muscle is actually visible there, and it looks like it is an irreparable tear. However, like Deepak mentioned, there are quite a few tricks in our armamentarium, and with your experience, you can keep repairing these with great efficiency, and I'm going to share them in my next few slides. The first thing you need to do is do an intra-articular release. That is, you need to release the coracohumeral ligament from the rotator interval area. So this is the left shoulder looking from behind. I'm releasing at the base of the coracoid all the adhesions between the cuff and the glenoid, and I'm releasing the coracohumeral ligament, and that gives us significant excursion. Let's remember she had an intact subscapularis and the biceps was severely frayed, so I had tenotomized it considering her age. I then entered the subacromial space and did a thorough juxta-articular release, which releases the posterior cuff thoroughly. So we have released the anterior area, we are releasing the superior area and the posterior area now. And having done this, you will immediately encounter a thick bursal curtain. Now, unless you release this bursal curtain, you will not get the repairability. So yes, you need to respect the bursa. Deepak has driven a very important point that the bursa has got excellent vascularity. However, the bursa, which is thick like a curtain behind, has to be released before you are sure that the reducibility will come. And how do you differentiate the bursa from the cuff? So both of them look similar in some cases. So you need to rotate the arm into internal, external rotation. And when you rotate, what will move is the cuff. What will not move is the bursa. And then you can confidently release this bursal curtain. Try to preserve the bursa on the medial side because that's where the vascularity comes from. The lateral side is too flimsy and can be released. And having done this, you will suddenly realize that quite a few of these tears are reducible. And this is the case. And that's what is the final decision on arthroscopy. So I'm happy with the reducibility now. I've assessed the tear pattern. So it's actually a complex tear pattern. You can't really label it as any particular tear pattern. I then placed traction stitches. So that's the leading edge.
Yeah. Nagaraj, can I just pause for a second just to get the views on the faculty?
Yeah.
So, Dr. Antav, are you there? Okay, Dr. Desai. So we see here that predominantly there is a good amount of tendon loss. Despite us doing the releases and getting it to the footprint, there is some good amount of tendon loss. So if you think about repairing it, what sort of configuration or suture techniques are we looking at?
I would First of all, I'm not yet very convinced that there is such a huge tendon loss. I think there is a good amount of tendon there. And it seems like a posterior superior cuff tear, supra and infra. And it should come, I would basically aim to reconstitute the anatomy. So pull and push the cuff in all the directions, identify the pattern of tear, and if you reconstitute the anatomy, it will heal if it's a secure repair.
Deepak, anything different?
No, I think Dr. Desai has made that point very clear. So there is enough tendon there. Nagraj has released it quite well, so this is repairable.
Okay, Nagraj, please continue.
So we also have to rely on a good biological environment for healing. So we have to make sure that the tuberosities are well prepared. And you need to make sure that you're not too aggressive with this, because the bone quality can be quite poor in these patients. So you can use your shaver in the reverse mode. You need to be prepared to medialize, because the next thing in mind is to create a low tension repair. So you need to come with your anchors right at the edge of the cartilage. You can also curate out some area so that you are having a medialized low tension repair. Up to 10 millimeters biomechanically has been validated as you can medialize. You need to have a strong fixation point in the posterior area. So I use triple loaded anchors. You need to make sure that the infraspinatus is firmly fixed to that area. You need to create crimson duvet like bone marrow vent so that there is biology under the cuff. And I create a Mason-Allen configuration. So with my triple loaded anchors, I pass mattress stitches and I pass a simple stitch medial to the mattress stitches. All of them are about few millimeters away from the muscle tendon junction. And I do not I make sure that there is no tension in my repair. In this case, I was happy to also put lateral row anchors because I was confident that the tissue was quite flexible. However, here again, I make sure that there is no over tensioning. This is a rarity. You might land up doing a single row repair. In this case, it was a rarity. I could achieve a fairly good reduction. And that's her footprint repair. And this gives you a good confidence that she's going to do well. She was put on a rehab. Now, what's important to understand is whether pseudoparalysis can be truly reversed in these acute and chronic tears. We all know that acute tears do very well. We all know that pseudoparalysis can be reversed. However, the patient in question is a patient who's acute and chronic, and this is an 8-month follow-up. A pseudoparalysis is completely reversed with good scapular rehab. This was all during the lockdown, so rehab was not proper. She also got her active external rotation back. And this is her recent follow-up at 16 months. So she's got pure shoulder glenohumeral movement. And she's got extremely good external rotation. I've had the opportunity of getting a follow-up MRIs to see what is the healing. So we can see a very good healing of her tendon onto the tuberosity. We can see a very good healing of her infraspinatus also. And this is what is very, very gratifying. So there is, the sagittal image shows that there is an improvement in the muscle volume. Fatty infiltration, we all know, is something which is irreversible, but muscle volume is something that does improve. So we need not be so worried about loss of muscle volume. So you can see that our infraspinatus muscle volume has improved significantly. Another gentleman, he's actually a 69-year-old gentleman. Again, pure pseudoparalysis. The same criterion were kept in mind and complete reversal of pseudoparalysis and very good external rotation. So my take-home message is pseudoparalysis is reversible in select cases. Muscle volume does not improve. Muscle volume does improve with healing of your repaired cuff. The red flags to remember are if there is an anterior superior escape, if there is a hornblower sign positive, if there is an advanced Hamada stage, that is a reduced acromihumeral distance, and more than grade 3 fatty infiltration. Now let's remember that reverse shoulder is not until now validated for patients with non-arthritic shoulders. So the take-home message is reverse shoulder is the ideal indication for pseudoparalysis with a patient with arthritis. But for the non-arthritic shoulder, with these criteria in mind, you can attempt an arthroscopic solution.
Great. Thank you, Nagraj. While you upload on your next case, so very nicely highlighted points on massive cuff tears that as Dr. Desai mentioned, that just don't rely on MRI to judge on repairability. Arthroscopic evaluation, proper releases without causing devascularization of the tendon is important, and a sound surgical repair construct really helps. Obviously, there is a risk of re-tears in the long term, but otherwise these patients would do well in terms of pain relief and restoration of good function. Any comments from the panelists on this case? Okay, so Nagaraj, please, if you can do this second, and that will be the last case in the interest of time. Thank you.
Yes, I'll try to keep it brief and try to encourage as many discussion as possible. So very unusual case of shoulder instability. It has been presented in the past, and I have the follow-up of the patient now. It's a good case for discussing the entire gamut of shoulder instability presentations. That's why I'm repeating this presentation. So it's a 31-year-old right-hand dominant male who presented with me only with complaints of shoulder pain. He just had these pain episodes twice or thrice in a span of 2 years when he was doing overhead activity like playing cricket. The history was that he had a fall from motorbike 2 years back. He had some pain in his shoulder for which he didn't even feel like consulting a doctor, and he carried on with his activities. He had pain only for a day. He has had no formal dislocation or subluxation episodes. This is his plain X-ray. On the plain X-ray, we look at the contour of the glenoid and make sure that there is no bone loss. Because of his pain, he consulted an orthopedic surgeon who got his MRI done. And as you can see, the MRI has been done for history of pain, not for instability. But what's surprising is that he's got a significant Hill Sachs, which is almost 0.3 centimeter deep. He's got no significant anterior tissue labral remnant. And he already has about 18% bone loss. Now, this is something which is very, very, very strange, because a patient who's never had a dislocation or subluxation can also have all these features, which suggest that a patient has had at least 15 or 20 dislocations or instability episodes. What we can see on the key images is that there is a straightened anterior border. For the interest of the audience, whenever you see this, you need to consider that the bone loss is in the range of 20% or above. You need to look at the Hill Sachs. This was in 2017, where we were looking at the dimensions of the Hill Sachs, that is the depth, etc., and the size, etc. We all know what matters is the location and the orientation. Dr. Desai nicely mentioned about the on-track, off-track concept, and our recent MRIs are all having the on-track, off-track pathology. This could be considered a borderline case. Let us go ahead with the presentation. So I got a CT scan done. Which actually showed that there is a posterior subluxation of the humeral head. The Hill Sachs is actually quite deep, meaning it's a significant Hill Sachs, and there is a significant bone loss. So it's in the range of 23%. To make matters worse, there was an ossific body which was suggestive of probably a Hagel lesion. So we have a case scenario where probably there is a posterior labral pathology, there is a significant anterior labral pathology with poor tissue quality, there is significant glenoid bone loss, there is moderate humeral head bone loss, and there is a Hagel lesion. So with this in mind, these are the images. These are the images of the CT scan. Before I go ahead with this, I think I'll go ahead with this for the benefit of the audience. So, and even today we have this as the article, which is I think the benchmark, which talks about bipolar bone loss. And they have come out with a treatment algorithm, which roughly we follow. We all know that we cannot rely completely on this algorithm. And typically this patient would come in this category. He's got less than 25% bone loss. He's got an off-track Hill Sachs lesions, probably. So I would go ahead with an arthroscopic Bankart repair and a remplissage. And considering that the case is very rare, I am going to keep Latarjet as a backup. So this was my understanding. So any points at this stage from the audience, from the faculty? So we are dealing with a case with very poor labral remnant, off-track Hill Sachs, moderate to significant glenoid bone loss, and a Hagel lesion.
Dr. Amtav, are you there? Yes, Deepak, you can start here.
So what were this patient's symptoms when he presented to you and you got all these investigations done?
His typical symptom is that when he takes his arm into abduction, and of course the episode of that increased, and that's why he came to me. But typically he says only when he takes it into a particular posture, he does feel discomfort and pain. He has never felt it even sublux out. He doesn't say it pops out.
And this is his non-dominant arm. This is the non-dominant arm.
It is his non-dominant arm, yes.
Yeah. Okay.
So I will, sir, Desai sir, I'll go ahead with the examination videos and then I will take your opinion. Is that okay?
I wanted to just get some information on the soft tissue, ligament laxity, etc.
Yes, so the examination videos are under anesthesia and he had no ligament laxity whatsoever. But I would like you to see his examination videos before you give us your...
Because I want to know whether he's MDI.
Yes. So he's got a significant load and shift at 90-degree abduction. He's got a posterior jerk test. He had no sulcus. He had absolutely no ligament laxity signs. He's on the tighter side, actually. So now, with this scenario, we have a posterior labral pathology, we have a Hill-Sachs, we've got a moderate amount of bone loss, we have Hagel in our mind. What would be the approach? Deepak, would you like to go ahead?
So, I'm not sure why. So, if this patient has very mild symptoms for a non-dominant arm and possible hyperlaxity, probably, irrespective of whatever the MRI or the imaging shows, so I would tend to first suggest rehab to him, because I don't see sufficient symptoms to recommend surgery for him. And I agree with the MRI. The bone loss is huge, but he's never had a dislocation, not even a subluxation, and it's just a little bit of pain. So I would hesitate to recommend surgery at the onset, right at the onset. Unless he comes up later with a dislocation or some symptoms, then it's a different thing. But definitely not at the onset.
But Deepak, we all know that anterior instability, unlike posterior instability, is very unlikely to respond to rehab, especially with so poor quality labral remnant, with so much amount of bipolar glenoid bone loss. He's very unlikely to respond to conservative treatment. So let's say he doesn't respond, he comes back to us with the same symptoms. What would be your treatment plan?
So I would still, I think it's a very unusual situation. There's somebody with so much of anterior bone loss is just, is showing no dislocation. So if he comes back with a subluxation or dislocation, then yes, but otherwise, probably I would just treat him symptomatically.
Desai sir, would you like to suggest? Now the patient is on table. What is going on in your mind and what would be your options?
So number one, if you tell me that he did not have any clinical signs of generalized ligament laxity, I would be looking very carefully at localized shoulder capsular laxity. You can have, like I said in my talk, you can have generalized ligament laxity or poor capsule mainly of the shoulder joint and no generalized ligament laxity. This is high on my mind. Can you get such a significant glenoid bone loss without a dislocation? Yes, you can. In people who have laxity of the capsule, you can keep subluxating on the edge. The humeral head can keep rolling over the edge of the glenoid repeatedly, enough to cause erosion of the glenoid bone. But these patients will have probably instability in other directions also, as you were trying to show us on your examination under anesthesia. So number one, your antenna should be up. This is not a simple, straightforward case. Counsel the patient well. Don't jump into any aggressive bony operations at the first go, like lethargia, because you have a multi-directional, and if you do a lethargia, you are in trouble. I don't believe he will have anterior capsular damage, posterior damage, and a Hagel. Doesn't happen like that. I'll be very skeptical about your Hagel diagnosis, but if he is refractory to conservative treatment, scope him with an open mind.
Nagaraj, do you have Dr. Narvekar as well? Can he comment, please?
I didn't know he was here. Narvekar sir, any tips at this point of time? What can we expect on the arthroscopy? We have all decided we are doing the arthroscopy. What can we expect?
So
actually, Nagaraj, I think I would be biased in this case, so I really wouldn't like to.
Okay, sure. So Dr. Antav.
Yes, so therefore, sir will be biased.
Sure. So Dr. Antav has actually, there's some issue with his Zoom connection, but he sent me a message on the YouTube that for this patient, his recommendation would be to do a bony procedure like a lethargy.
Great. So the entire spectrum of disorders have been discussed.
Nagaraj, just a sec. You've done all your neuro investigations for other things, yeah? Charcot and all that is all clear, yeah?
Yes, sir. Yes, sir. Absolutely.
Epilepsy and any neurological problem, all that is eliminated, I presume.
Absolutely. And you are talking about the Gagey hyperabduction sign. He didn't have it. You're talking about abnormal external rotation. He didn't have it. You're going to see the follow-up of the patient also. You will be convinced. And also the arthroscopy picture is quite interesting.
Okay.
So this is the arthroscopy. We did a dry arthroscopy. At that point of time, we were quite keen to see if it's engaging. This is just a matter of academic interest now, where we take the arm out of the traction. and try to see if it's engaging. Because the question of another controversy is the role of remplissage when we are planning a bony procedure. We'll come to that later. So he did seem to have a very engaging kind of a Hill-Sachs. So that's roughly where it engages. He pops back, engages, and pops back. So we know that the Hill-Sachs is significant, but at that point of time, we went ahead, did the arthroscopy. There was a loose body, which was retrieved. However, it was a cartilaginous loose body. Dr. Desai was absolutely right. It's very uncommon to get this combination. We looked thoroughly because we had the anticipation. We were very thorough in our diagnostic round. We looked for the capsule anteriorly. We looked for the capsule posteriorly and made sure it is normal. There was significant bone loss. This is what was very, very disheartening. So very poor quality anterior labral remnant, something that I was sure is not going to sustain this sort of instability examination findings that the patient had. So this is a patient who definitely has very severe signs and very less symptoms, but this is what it is. So I decided, let me prepare the anterior glenoid, let me mark it, and let me now think about doing a bony procedure. As I said, I was prepared in terms of keeping all the equipment ready. He also had a very prominent posterior labral tear. You can see there is no laxity or a pouch, a significant laxity in the posterior pouch. So I went ahead with my posterior inferior labral repair. There's nothing much new in that. We got a nice 2-anchor repair.
His anterior band seems to be less than 4.
Yeah, I agree. It seems to be so. Absolutely. Yes.
So at this point of time, I was quite clear that this bone loss and this tissue quality, it is not going to sustain him in terms of preventing him from that sort of examination findings he had. And now I decided to go ahead with an open Latarjet. So I turned him over and I did an open Latarjet. Nothing much to say there here. That's his post-op images. That's his follow-up. This is actually his 4-year follow-up. He's got no apprehension. That's his follow-up MRI, which shows a very nicely healed posterior labral repair, a good integration. There is some osteolysis, which is expected. Before I go to this point, anybody would have done anything differently? Any points to be added? Narvekar sir, now that we have discussed what I have done, anything you would have done differently?
No, I think it is exactly what I would have thought we would do once you had put in a scope inside. Because once you see that degree of bone loss and no articular cartilage there, I'm only surprised that he had such minimal symptoms, in terms of going into abduction, external rotation, and still not complaining of any apprehension. So, like Deepak said, that just looking at the patient get into a surgical mode like you had done at that point of time. But probably, I do not know, it all depends upon the patient's psyche at that point.
Anything to add from Desai sir? Deepak?
No. Did you not, why did you not do a remplissage?
Yes, so that is this slide has been kept for that purpose itself.
Instead of a Latarjet, Bankart with remplissage. Just want to know your thought process.
Because with my experience over the years, when I see a tissue quality where I'm liberating and I'm just fraying, it's just cutting off, I know that my stitches are just going to be hanging there. It is just waiting to cut off. So yes, remplissage would have added some confidence, but not enough for me with that sort of poor quality tissue that it is going to hold on. It is waiting to fail. So I didn't want 2 surgeries for the patient.
Yeah, Nagra, that's a very important point, because even in my practice, I have noted that there are times where the labrum is hardly there and we have to rely on the capsule. So my question to the panelist is that, would you still, in the absence of any significant or subcritical bone loss, would you still go ahead and do a capsular procedure, and perhaps for those who believe in remplissage, add a remplissage to make sure that that capsular repair is offloaded till it heals, or would you consider a bony operation?
I think Shreyash, with a guy who's not having a very high level of contact sports, I would still probably do the capsular, because if you liberate it well and if you give proper tension, use the tensionable anchors, wherein you would go more proximally with the anchor first and tie them and then go, not the normal sequence, and add a remplissage. I think it.
Yeah, I think that's a very important point. I've learned from one case, a similar situation, not bone loss, very poor labrum, did a capsular repair, but didn't do a remplissage for a small heel sacs. And 4 months later, he had an episode. It was traumatic, but he had one. So I think so. Dr. Desai, Deepak, anything different?
Just want to throw a question to the faculty. Same case with very good soft tissue. What would he do? Imagine this patient had very good quality soft tissue, and this is the rest of the scenario remains same. 23% glenoid bone loss.
I think I'll go in first. If I had a very good tissue quality, I would probably do arthroscopic repair with a remplissage with the counseling, and I have evidence in my support. The treatment algorithm still exists to counsel the patient that he is less than 25% bone loss with the counseling. Now, what's important to note here, he's an absolute office goer. He is a non-contact person completely. He has no ligament laxity. He's no ominous signs. So on the so-called scoring, he scores well. So the bone loss is the only problem. It is not a significant bipolar bone loss, meaning the Hill-Sachs is not very off-track Hill-Sachs, so to say. So I would do the soft tissue procedure.
But you are familiar with the lovers of remplissage and the meta-analysis of February 2021. That remplissage has a high failure rate when you have a glenoid bone loss which is greater than 10%.
Yes, so that's the reason for the counseling, that he will be a candidate for a bony procedure in future if he fails. But at that point of time, there was no justification because the tissue quality was good.
Dr. Desai, do we know
Sanjay,
in that systemic review, were the patients very active or were they sedentary or less active?
It was a mixture of both. It is February 21 arthroscopy. You can, I don't have it.
Again, Sanjay, let me just remind you that particular article is not by an Indian person. It is from an European or an American person. So the patient profile is different, and it is a patient profile that you basically, base your treatment algorithm for Bankard's repair rather than a Letarge for these patients.
Yes, sir.
So I think it is not very fair to say that, would you do that just you can quote that particular article, I think.
No. It is, no, that's when there is a, sorry, I beg to differ. In a scientific discussion, quoting a meta-analysis of I don't know how many articles, it's a fantastic study, is very important with a corollary that you have to address your patient population. That we all know, and that everybody does. But science cannot be ignored.
One question to Sanjay.
Yeah.
Hi, Sanjay.
Yes. Hi, Vijay. How are you?
I'm good. Great. So, Sanjay, how this is a very practical question. How do you counsel your patients when you are faced with such a problem?
How do you counsel your patient? Well, I mean, you can, at least this is what I do. I tell him that, look, these are the options available to you. You have an option of a relatively low complication rate arthroscopic soft tissue procedure, and you have an option of a more severe bony procedure with a higher complication rate. And these are the plus and minus. So, I mean, I will involve the patient in the decision making and not do it unilaterally by myself.
Would you, this is very important because you are a famous shoulder surgeon, and tomorrow if it's something that's, that you have to take a decision, how do you make that decision? Because I think it's very important these days, considering the time that we live in.
Like I said, I will counsel the patient, discuss the pros and cons, not give only the option which I want to do. I will give both the options, which is respecting the world literature and the science produced by the world with large volumes, and cater it to the population that we serve.
So we are dealing with two things here: eminence-based medicine and evidence-based medicine.
Correct.
So see, So what if it comes to your own family members?
It applies to anybody. It doesn't matter. To me, every patient is, I will look at it as my family member and do what I honestly feel.
Absolutely.
It's the best literature filtered through my experience, not directly literature. Literature, I repeat, which is filtered through my own experience. And I will produce that as the answer to my patient's problem.
But as a matter of fact,
Thank you, Sanjay. This is a very important message for the youngsters. Yeah, bye. Go ahead. Sorry.
Yeah, I would direct you to a very good, I would say, a talk by James Esch, where he basically spoke about evidence-based medicine and its contribution and your decision-making with your own experiences for your own patient population.
Absolutely. Yeah.
And he had a very wonderful mix of both, that you cannot. As a matter of fact, when you talk about evidence-based medicine, you are taking the decision away from you and trying to save yourself and using evidence of somebody else's evidence as something to propose or not to propose a treatment pattern. Whereas a good mix of both is what we're really looking at. And having said that, I also would like to know what is Deepak's opinion regarding remplissage. How often does he do a remplissage, or he also doesn't believe in remplissage at all?
Thank you. That's brilliant. Shreyas, this is a message for the juniors. You know, it's something that we can take up next time.
Absolutely.
Nice.
Nagaraj, we'll wind up, please. Excellent discussion.
I think
Nagaraj, well done.
Thank you. One slide I think we should finish off, because that's the last slide. And that was the point about remplissage. And if there is a significant bipolar bone loss in 2021, if the same patient had come to me now, and if there was a significant off-track Hill-Sachs lesion, I would consider doing this procedure in the beach chair. I would consider doing the Hill-Sachs, putting the anchor, passing the stitches through the infraspinatus, doing the Latarja, and then coming back and tying it. It's very important to do this in this sequence, because otherwise you will damage your remplissage when you're putting your humeral head retractor. And the threshold for remplissage is very low now. In the presence of Latarja, most of the cases will be covered, even if there is a significant Hill-Sachs. But we all know that there are cases with significant bipolar loss where this has to be kept in mind. So that summarizes the...
Shreyas, you didn't allow Deepak to give his opinion regarding remplissage.
Sorry, we didn't hear your voice. Deepak, please, I think your voice was breaking in between. Yes, Deepak, go ahead.
So you're asking me in general or for this case?
No, in general.
So in general, I think I would I think remplissage is a good procedure when done for the right indication. It does not lead to stiffness like a lot of literature suggests. If you pass your sutures correctly, you do the tissue bridging technique. Because a lot of these patients are also, they have some amount of hyperlaxity which actually compensates for the little bit of restriction that they get. But really, if you have significant glenoid bone loss, then the remplissage does not have any role, and it is the bony procedure that you must consider. And similarly, if the Hill-Sachs is very small, then you don't need to do it. Was there anything specific you wanted to ask me on that?
Dr. Narvekar, we can't hear you.
That's okay. Hello.
Yes.
Yeah, we can. I think he's muted.
No, I'm not muted, but I think there's some problem.
Yes, please.
So because personally, our experience with remplissage has been fairly good. As a matter of fact, unfortunately, because there is no restriction of movements, we tend to probably use it a little bit more often, just as a second line of restraint for the head from going anteriorly, translating anteriorly. Now, the question of whether you can treat a bony problem with a soft tissue problem, I'm not too sure about that. We always do that in a lot of other cases. But, it's something which my own experience tells me that it is probably a procedure which is very malignant.
Yeah, I think Dr. Narvekar, a very important point highlighted, apart from the article which Dr. Desai has mentioned. Obviously, I will be reading it. there is certainly a trend towards a low threshold to add a remplissage, because certainly it is, if at all, rewarding with very little compromises in outcomes. So thank you very much, all of you, for taking your time off and participating. Thank you, Nagaraj, for your excellent share of cases. I would request the panelists and the faculty who logged in to please switch on their videos. And once again, it was an excellent knee and shoulder session. On behalf of the Bombay Orthopedic Society, I'm grateful to all the faculty, also to Rujita Mehta and the BOS committee. And I'd hand over now the proceedings of closing remarks to Rujita Mehta.
Thank you, team. Thank you, BOS.
Show, it really brought out the body of work that has really gone into a very niche branch like arthroscopy over the years. And for me personally, I think it was a very, very eye-opening experience. If I had to just ask one last question as a parting shot to both the conveners, to pick one practice-changing idea, Pranjal, because that is our theme in the knee, and to Shreyas to pick one top practice-changing idea.
Wi-Fi is low.
What would that be?
Oh, yes. Okay. Go ahead.
What would that be?
So talking about the shoulder first, certainly I think it applies to the knee as well. What we come to know now in the last 25 years is that one surgery or one treatment does not fit all. It has to be directed depending on the extent of the pathology, the patient age, the activity, and the demand. So that's what we have learned in these last 25 years.
Hello, Rujita, I couldn't hear your question. I'm sorry.
Thank you very much. And thank you very much for inviting me. And one thing that I thought I learned in this session, I mean, sitting with some of the eminent surgeons in Mumbai, that every patient is different. Each individual is different. I think we'll have to focus on his needs or his or her needs, and then go ahead with the planning. And if we are in trouble, we have friends.
So thank you. It's really been very enlightening. I think Vijay and everyone has really summed it up. But what I have gained in this, and the one idea which has come through to me, is that there's a lot of focus now on realigning everything versus excising and repairing. So I think that's really the way to go forward. And wish you all a very safe time from now on, and keep up the good work. Bye-bye. Thank you, everyone.
Thanks for being Thank you.
Keeping the sessions going live with all the interaction. Bye-bye.
Thank you. Bye-bye.